College of Law and the West Virginia Law Review's symposium. I want to also welcome you this morning not only to the symposium, but to the John W. Fisher Second Lecture in Law and Medicine here at the College of Law. This lecture series is made possible through the generosity of Dr. Thomas S. Clark and his wife, Jean Clark, their two sons, Chad and Stuart. It was established in 1998. The Law and Medicine Lecture is one of 10 that this generous couple created across the campus in various disciplines. This one, in particular, honors their close friend, John W. Fisher, upon becoming the 15th Dean of the College of Law. The Clarks, as you might imagine, are very loyal mountaineers. Dr. Clark earned his medical degree at WVU in 1975 and became the medical director of Mylan Pharmaceuticals and former CEO and owner of Clinical Pharmacologic Research Incorporated. Jean Clark completed her BA at WVU in 1967 and a master's in education in 1974. She's also served the University Foundation on its board of directors. Now I want to tell you about the man that they were honoring with this incredible gift. John Fisher, who's with us this morning, sitting in the back, was the first William J. Mayer Jr. Dean. He is now the William J. Mayer Dean Emeritus. He is also a loyal mountaineer, earning his BA and JD at WVU and serving the university over many years in many capacities. The West Virginia Supreme Court of Appeals refers to him as the state's foremost authority in the field of property law. And as a property law professor myself, I just refer to him as the guru of West Virginia property. On behalf of the College of Law community, our thanks go out to the Clarks for their generosity and for their recognition of the important and beneficial connections between law and medicine. Today's Law and Medicine lecture is in conjunction with the West Virginia Law Review's symposium, focusing on prescription drug abuse. The Centers for Disease Control classify prescription drug abuse as a national epidemic. According to the CDC, 1 in 20 people aged 12 or older in the United States have used prescription painkillers for non-medical reasons. This is not only an epidemic in the United States, it is truly a tragedy, ravaging families and communities. I know that all of us sitting in this room in some way have been touched by prescription drug abuse. We may even know someone who is addicted or has died or is serving time in prison because of prescription drug abuse. My heart goes out to all of you here today who have lost a loved one to prescription drug abuse. Today's lecture, therefore, and panel will be very, very important, not only to West Virginia, but to the nation, in trying to explore the very best solutions we can to this national tragedy. So I welcome you here this morning for us all to engage in achieving solution to a problem. I also want to welcome you to West Virginia University College of Law. I am not in control of the weather, but we are pleased to have as many of you here today as could make it. You'll now hear from McKinney, who is the editor-in-chief of the Law Review, who will introduce the program.
Thank you, Dean McConnell. Esteemed speakers, deans, faculty, and members of the community, thank you so much for attending today's Law Review Symposium. Before we continue today, I would like to recognize the current members of the West Virginia Law Review. Would the current members please stand? Also, specifically, I'd like to thank Patrick Callahan, Kristen Brumley, Natalie Arvisu, Margaret Abush, and James Jolly for essentially putting this entire event together. Without them, this wouldn't have been possible. As always, the West Virginia Law Review appreciates your continued support. This continued support allows us to celebrate an important milestone for our law review. This year marks our 120th anniversary. With this, we join the ranks of Harvard, Penn State, and Yale as the fourth oldest law review in the nation. And as part of this milestone, we decided to choose a symposium topic that no other law school or law review in the nation has fully and holistically addressed: prescription drug abuse. Prescription drug abuse is not just a West Virginia problem. Prescription drug abuse is a nationwide epidemic that the law currently struggles to manage. The point of today's symposium is not to just raise awareness about the issue. Today's symposium instead will discuss the current state of the law on this issue, and more importantly, begin the discussion of what can and should be done to improve it. With that, I'll let our MC, Professor Prochet, begin our symposium. Thank you.
Thank you, Ahmad. I'm so happy to be here to serve as MC today because I have a soft spot in my heart for law reviews generally, particularly the West Virginia Law Review. As a former member of the Law Review, I can say that it was probably the favorite thing that I did in law school, and I hope you feel the same way. I know as someone who's on the other side of the process now, I can also say with pride how well received you are and how well respected you are among scholars who work with you. And you do excellent work, and we're really proud of you, both in terms of the work that you do and the reputation that you uphold here. So congratulations. The topic that we are going to be talking about today is obviously important in West Virginia, but it's important throughout the world. In fact, it's a nationwide problem, and it's affecting people really everywhere in the world. And unfortunately, I don't know that enough people are really talking about it in a context like this with a sort of holistic response that seeks to address all of the legal aspects that might go into fighting a war on so many fronts. So today, the Law Review has put together a really excellent program meant to target each of the legal branches' efforts to stem the tide for prescription drug abuse. So we have someone from the legislative branch, our very own Senator Joe Manchin, who will be speaking to us today. We have people who will speak about the policy response and from the executive branch, the agency response that is targeted at this complex issue having to do with prescription drug abuse, because they are legal in some respects and then tip over into a world of illegality at some point. So it's not an easy problem to solve. We also have we'll have discussion about how the courts are going about addressing the problem. So it's a multifaceted discussion today. We're very excited that our first message comes from Senator Joe Manchin, who represents the great state of West Virginia in the United States Senate. He can't be here with us today. We were sure to order excellent weather for the entire month. It was 6-8 months ago we put that in. Unfortunately, obviously every day almost this winter has been a hot mess when it comes to weather, and his voting schedule has changed, which meant that he couldn't be with us today. The scheduling conflicts were just too great, unfortunately. But he has recorded a message for us that we're really happy that he was able to share, because he's going to share with us what he's doing and what the Senate is, particularly with the work that he's doing in the Senate, is thinking about in terms of ways to address the problem of prescription drug abuse. So with that, I give you a video image, I suppose, of Senator Manchin.
Hello, this is Senator Joe Manchin, and I want to thank the West Virginia University College of Law and the West Virginia Law Review for making this very important symposium a reality today. Prescription drug abuse is an epidemic that plagues every community in our state and across this great country. We've reached a crisis point, and ignoring the problem is simply unacceptable. We have a responsibility to this great nation of ours, especially to our children, to win this war on prescription drug abuse. That is why I have fought to reschedule drugs containing hydrocodone, which is a highly addictive substance found in painkillers such as Vicodin and Lortab. Today, hydrocodone is the most frequently prescribed opiates in the United States. More than 139 million prescriptions for hydrocodone containing products were dispensed in 2010, and 42 tons of pure hydrocodone were dispensed that same year, enough to give every man, woman, and child in America 24 Vicodin pills. That's why in 2012 I introduced the Safe Prescribing Act to do what the Federal Drug Administration had failed to do for more than 14 years, which was to reclassify hydrocodone drugs from a Schedule III to a Schedule II controlled substance. The rescheduling would have helped keep these addictive pills from getting into the wrong hands. Although the bill passed the Senate unanimously, it was stripped out of the final FDA bill due to the involvement of special interests. But we didn't give up. And last fall, the Federal Drug Administration finally followed through with our long-standing request to reschedule these addictive painkillers. That decision will undoubtedly save hundreds of thousands of lives. In addition, I have introduced pieces of legislation to battle our war on drugs, including placing a federal ban on synthetic drugs marketed as bath salts and plant food, and cracking down on the so-called pill mills, which are the places people go to get powerful prescription drugs that they do not use for medical reasons. I am also proud to co-sponsor the Prescription Drug Abuse Prevention and Treatment Act, introduced by Congressman Ray Hall and Senator Rockefeller. Their legislation focuses on prescriber and patient education, proper prescribing practices, increased federal funding for state prescription drug monitoring programs, and comprehensive reporting of opioid-related deaths to help guide our solutions. Too many families and communities have been torn apart by prescription drug abuse. My heart goes out to those families and communities, and they need to know that I am determined to do everything I can to keep prescription drugs out of the hands of those who abuse them. I'm also committed to seeking treatment for these individuals instead of turning to incarceration as a first response. We need to treat this epidemic the way we would any other disease. So today, as you continue this important symposium, I once again thank the West Virginia University College of Law and the West Virginia Law Review for their leadership in this fight. Let's continue to work together to make a difference and help curb prescription drug abuse for all West Virginians and Americans. Thank you, and God bless you.
Obviously, we'll be blaming the weather for that video glitch as well. It will be blamed for all ills today. So, as you heard from Senator Manchin, obviously this is a legislative problem that he's seeking to try to address in the ways that he specified. But no legislative strategy is complete without understanding the policy behind it. That might sound familiar to a lot of you who have sat through at least one law school class. And the legislative strategy and the policies behind it are obviously myriad and complicated and can need to be understood from multiple perspectives. So for that, we have asked Michael Barnes from the Center for Lawful Access and Abuse Deterrence to speak to us today. He's the executive director of that organization, and he has also served as confidential counsel in the White House Office of National Drug Control Policy, which I think is probably one of the cooler titles you can have. Confidential counsel, I mean, it sounds very spy, kind of like a underground sort of cool job. And he is nationally known for his work in helping develop drug abuse prevention strategies. So we're so pleased to have him here. Please help us welcome Mr. Michael Barnes.
Good morning. Thank you for the opportunity to be here to share CLAD's perspective on the efforts that are necessary to reduce prescription drug abuse. I'm Mike Barnes. I'm Executive Director of CLAD. We're located in Washington, D.C. I'm going to give you a quick preview of what I intend to discuss today. I do intend to cover a broad range of topics with the hope that we can touch on some areas of interest for each of you and also be able to stir up a discussion that will pique the interest of the audience members in topics that they might otherwise not have considered related to prescription drug abuse. So I'll give you an overview of the organization that I run, CLAD, and then talk about the responses to prescription drug abuse that we have seen to date from the federal government, from state governments, as well as from corporations, and then I'll also talk about some opportunistic responses to prescription drug abuse that should not be confused with proper law and policy to deal with the issue. We'll talk about the evolution of the epidemic, and that really is the theme of the work that I do on a daily basis now. Fortunately, we are seeing progress at reducing prescription drug abuse, but as a result, we're seeing that the epidemic is evolving and new challenges are arising that are associated with the issue of prescription drug abuse. We'll talk about the success of certain supply reduction measures and the need for greater demand reduction. And then I'll talk about how the legal community can support the efforts that organizations like CLAD and our partners are pursuing to deal with the issue of prescription drug abuse. And then we'll have plenty of time for discussion, and I urge you please to have questions, bring questions to me, and do take part in what I see as an essential conversation about the issue of prescription drug abuse. CLAD's mission is reflected in its title. The Center for Lawful Access and Abuse Deterrence aims to ensure adequate consumer access to quality health care while also preventing health care fraud and prescription drug diversion, misuse, and abuse. And when I say misuse, I intend to distinguish that term from abuse. Misuse is what I see and what is typically defined as medical misuse, where one has a medical need that is not appropriately addressed by adequate access to health care, and therefore the person has to access the medications illegally, even though there is a legitimate medical need. Abuse is, of course, when one uses medications for the purpose of getting high. Our activities really are focused on three particular types of duties. We provide information and analysis. If you take a moment to look at the CLAD website, you'll see that we do try to catalog information about the issue from a policy perspective. We don't necessarily cover the stories that arise about the tragic deaths in communities or the new organizations that are popping up in response to this epidemic, but we do discuss the policy responses. And we have a number of those issues categorized on our website where you can view the information according to whatever topic might be in your interest area. We provide policy leadership and consensus, trying to bring together the representatives of the governmental, corporate, and professional sectors and getting them to agree. And we're fortunate that our organization has actually been able to unite the pain treatment communities with the abuse prevention communities, two organizations or two groups of individuals that never really got along, one seeing the other as trying to take away vital medications, which leads to suffering when those medications are taken away, and the other seeing the opposite end of the spectrum as the group of individuals who are pushing drugs into the communities. And so they have come together, and we have a very broad-based consensus that we're proud to say proposes moderate solutions to prescription drug abuse. We try to organize these groups so that we can harmonize their efforts and ensure that the minimal resources that are available, because there are not enough resources available to us to deal with prescription drug abuse, are used in the most optimized way. Right? So we consider coalition building and then the unification of efforts and sharing of resources to be a vital part of our mission. So I'd like to get your impression as to whether or not you believe that in the United States we are making progress toward reducing prescription drug abuse. Are we seeing this problem get worse, or are we seeing it get better? So if you think that we are seeing progress toward reducing prescription drug abuse, would you please raise your hand? One. Great. Thank you. 16% of Americans actually believe we are making progress, but 84% believe that we are not making progress toward reducing prescription drug abuse or dealing with other mental health issues. I'm a part of that 16% because I've been working on this issue since 2003 and with CLAD formally since 2008, and I've seen some of the progress that we have made. So this is where I'm going to go into some of the responses that we have to prescription drug abuse, and I do know that just because there's been a response doesn't mean that there is progress. We need to see that people are not dying, people are not overdosing, that families and communities are not being ravaged by prescription drug abuse in order for us to say that there is progress. At the federal level, we're seeing prosecutions under the Controlled Substances Act primarily, as well as DEA enforcement activities. And this is an opportunity for me to distinguish the two activities that DEA is charged with responsibility for. The first is ensuring that there's an adequate, safe supply of medications that are controlled substances. And the other is, of course, ensuring that those medications are not diverted from their proper uses to illicit uses. And so you've got the cop-like activity that DEA is outstanding at, and then you've got the regulatory activity that DEA is very challenged at. We'll talk about that. But part of their regulatory enforcement recently has been a law enforcement type approach of raiding distributors and pharmacies in Florida. Now, certainly, we need to make sure that distributors and pharmacies are responsible and abide by rules of ethics as well as rules of professional licensing boards. But I don't know necessarily that the DEA enforcement measures have been effective. What I see instead is that the large chain pharmacies are now imposing a knee-jerk reaction on consumers and withdrawing access, restricting access to medications. So there is an effort in Washington, D.C. to ensure that there is a more balanced approach on the part of the DEA and the federal government more broadly to dealing with the issues of prescription drug abuse and more specifically to regulating on the issues of controlled substances. The Federal Food and Drug Administration has imposed a REMS, Risk Evaluation and Mitigation Strategies requirement on the manufacturers of long-acting and extended-release opioids. And initially, this plan was hopefully going to require that each manufacturer of a medication develop a unique risk evaluation and mitigation strategy for that particular medication. Unfortunately, the Food and Drug Administration came out with an across-the-board classified REMS that only really provided for voluntary education that is funded by the pharmaceutical industry. So those of you who are interested in the regulatory aspect of dealing with prescription medication diversion and abuse will hear about REMS. And that is the FDA's authority to make the manufacturers take certain activities, to take certain steps to reduce the abuse of their medications. But REMS really at this point is largely a voluntary activity for prescriber education. The resources are valuable, and the resources that come from this effort are certainly being used by prescribers, and we're seeing some results from that. But REMS could be stronger. It does, by law, have to be individualized by medication, and that's not something that the FDA has recognized to this point. The Secure and Responsible Drug Disposal Act will hopefully soon allow us to dispose of our medications in pharmacies, which makes logical sense. It's where you go to get your medications. It's where the medications are stored safely. It's where professionals there know how to deal with consumers who have issues or questions with medications. Up to this point, you might have heard about prescription drug disposal days. Typically, the DEA has a national take-back day twice a year, and maybe your local sheriff will lead a take-back day occasionally also. But these sorts of occasional drug take-back days are good for two things, really. Public awareness. When people hear that there is a drug take-back day, there is a need for them to store their medications safely and to dispose of them safely. That's great. And then, of course, for those people who are able to participate on these rare Saturdays, yes, they can dispose of their medications. But really, there needs to be a long-term solution. And Senator Amy Klobuchar in the United States Senate did propose, and there was passed legislation, the Secure and Responsible Drug Disposal Act, that will provide for community-based, ongoing, permanent drug disposal options. We've been waiting for the DEA, the Drug Enforcement Administration, to move forward with the rulemaking process. It has been very, very slow, lamentably, and again, that is an indicator of the challenges that face the DEA as it tries to do its regulatory duties. But hopefully soon, we will see that the DEA regulations will match the intent of the bill sponsor and allow for pharmacy-based disposal in our communities. That will be voluntary. It will not be mandatory. So pharmacies will have the option of providing disposal, but it will not be required. The federal government has provided grant support for efforts to reduce prescription drug abuse. For example, medications that are less susceptible to certain forms of abuse, they're being supported, their research and development are being supported by the National Institutes on Drug Abuse. And we see that there are also grants that are available through the Hal Rogers Prescription Drug Monitoring Program that will allow states to get the money that they need to implement prescription monitoring programs. Prescription monitoring programs are typically systems that allow for pharmacists and other dispensers to input prescribing and dispensing data into a system that then allows for the prescribers to access that data to determine whether an individual already has a prescription before he or she writes a prescription for that particular medication. So the information that can be provided to those clinicians is very valuable if they access it. We'll talk more about prescription monitoring programs. But there is a federal grant program that is helping to move those forward in the states. 49 states now do have prescription monitoring programs. Abuse deterrent opioids. These are the medications that are less susceptible to common forms of abuse like melting and injecting or crushing and snorting, the types of things that allow an individual to access 24 hours worth of an active ingredient of a medication all at once. New medications like OxyContin, for example, have been introduced and approved by the FDA that are less attractive to would-be abusers and dealers because they have technologies that prevent them from being melted and injected or crushed and snorted. And so when OxyContin was released to the market back in, I believe, 2011, the data collection began, and we have seen there are a couple of published articles now that indicate that the attractiveness of the new OxyContin to would-be abusers and dealers is much, much lower than the prior formulation. So we know that these types of medications are working. And the FDA did a really good thing back in April of 2013. The FDA deemed that if a medication has been introduced to the market with abuse deterrent features, then the generics to that medication must also have abuse deterrent features. And this is a really, really great step towards shifting the market toward these safer medications. There needs to be more. There is a federal bill that has been introduced in the U.S. House. It's known as the STOP Act, introduced by Congressman Keating from Massachusetts. That would require the FDA over time to transition the market to safer medications. There is not a Senate sponsor yet. My organization is working with others to get the bill introduced in the Senate, and hopefully we will see the bill passed in the next year or two. But for anyone who might be representing Senator Manchin, if you've made it today, we would look to you, as we have in the past, to take the leadership to introduce the STOP Act on the Senate side, because we do need to make sure that there are appropriate incentives, if not requirements, to ensure that the generic manufacturers and all of the companies that are introducing to the market Schedule II controlled substances make their products as safe as possible. This is a basic issue of consumer product safety, and the government oftentimes has to step in to ensure that the market takes advantage of the technologies that are available. We've seen it with respect to seatbelts and airbags and the other sorts of safety precautions that continually and incrementally improve every year with automobiles, for example. New opioid labels. There has been some debate in Washington over whether or not the labels of opioid medications, those being medications that are like morphine or hydrocodone we heard about, or even heroin is an opioid substance. Those medications have been the subject of a great deal of scrutiny, largely because of the OxyContin issue that arose and now has extended to other opioids. The labeling has been changed now so that the use of the medications is now suggested only for pain that is severe enough to require around-the-clock opioid pain relief. And so this is intended to provide the prescribers the education that they need and perhaps a reason to step back before prescribing these medications. We heard the Senator talk about hydrocodone rescheduling. He had introduced a bill at the federal level that would have rescheduled hydrocodone from the middle level of Controlled Substance Act, the C3 level under federal law, to C2, which is the most restrictive level of controlled substance that is legal in the United States that has a medical use. Schedule 1 is for those illicit substances like heroin and cocaine and still marijuana. And then Schedule 2 is where the most dangerous medications are placed. And so hydrocodone will likely be rescheduled. That has not occurred yet because the FDA recommendation has gone through HHS, Health and Human Services, to the Drug Enforcement Administration. And the Drug Enforcement Administration now has to actually be the entity that will reschedule, and it has to go through a proposed rescheduling order. So the process will be relatively long. It will allow for the types of comment that will give the opponents to rescheduling a voice and an opportunity still to push back. But it's unlikely that they will be successful, and it is very likely that hydrocodone products will be rescheduled to the most restrictive Schedule 2 under federal law. Another important piece of federal legislation that has not passed but that has been proposed by your legislators from West Virginia, who really have, more so than anyone, taken a lead at the federal level on the issues of prescription drug abuse. This is one of the best bills that exists out there related to reducing prescription drug abuse by Senator Rockefeller and Congressman Rahal. It would require education for prescribers in order to register with the federal DEA in order to prescribe controlled substances. If you can believe it or not, an individual is permitted now to get the federal registration to prescribe powerful controlled substances without having any sort of proof of education on the topic. Granted, yes, they must be licensed, of course, to practice their particular profession, but they don't have to have any specific education related to controlled substance prescribing. It doesn't occur in the medical or other professional schools, and it doesn't typically is not required as part of continuing education courses. And so we are very, very doubtful that this will pass at the federal level. As the Senator mentioned, there are strong lobbies against certain types of federal measures to deal with prescription drug abuse. We saw that with the hydrocodone rescheduling bill that Senator Manchin referred to, and also the physicians' lobby is very strongly against the required education for DEA registration. So our organization has turned to the states to provide leadership in professional education to reduce prescription drug abuse. So that brings us to state responses to the issue. Very important to the community of legal practitioners is that there have been some really successful prosecutions that have sent a very strong signal to would-be rogue prescribers that they're under scrutiny. So we are seeing now, as we look at prosecutions at the state level across the United States, that as these resources that I referred to, like coming from the federal risk evaluations and mitigation strategies and coming from state required education courses, as these resources become available, the knowledge that practitioners have about the risks associated with controlled substance prescribing is growing, and it is becoming undoubtable, right? Everyone, if you read the news, you know that prescription drug abuse is an issue. If you're a practitioner, you know about it because controlled substances are inherently, by their definition, more risky than other non-controlled substance medications. But even still, we've been having to provide additional resources and education to practitioners. Now that those are fully being implemented, the notion that a prescriber would not have knowledge about the risks is pretty much unbelievable. And so the charge of involuntary manslaughter, which really goes to a harmful activity without due caution, but doesn't really require the knowledge and willful choice to proceed regardless. It's that element of knowledge that's lacking there. That's no longer the primary charge for someone who is prescribing in a rogue manner. It's second-degree murder, because that element of knowledge and intent is inherent now in controlled substance prescribing. So as practitioners learn that their prescribing practices can lead to charges of murder, we will see changes in behavior. Other types of state measures coming from legislatures as well as from licensing boards, mandatory checks of the data coming from prescription monitoring programs. As I mentioned before, the prescription monitoring programs collect the data about who has received a controlled substance, and that data is available to a medical professional before he or she prescribes a controlled substance. And so it's only useful if the practitioner accesses it. States are now having to require that medical professionals access the data because only about 20 to 30% of the licensed controlled substance prescribers were doing so. And we are seeing that it makes a difference. When they access the data, they change their prescribing decisions, one way or the other. It could be that they were not willing to prescribe, and then they become willing. So it's not only denying access to the care. Mandatory prescriber education, not happening at the federal level despite the good efforts of your legislators from West Virginia, but it is happening in the states. And what that means is that the prescribers, when I say that I mean physicians as well as advanced practice nurses and physician assistants who might under state law have the right to prescribe controlled substances, they have to get certain basic levels of education in order to continue to practice their profession. So as part of continuing education, like we as attorneys have to do in Virginia 12 CLE hours every year, and 3 of those must be ethics hours, right? Same thing is now applying to professionals in the medical fields where they have to get 16 hours every 3 years or so, and some states are saying 3 of those hours need to be attributed to safe controlled substance prescribing and abuse detection and referrals to treatment. And this is something that CLAD wants to continue to support because if you think about where the licensed professionals who are prescribing sit within our system of interstate commerce, they are the gatekeepers. The licensed professionals, licensed by state law, are the gatekeepers in the federal interstate stream of commerce, right? So you've got this interplay between federal law, Commerce Clause, and then the state's plenary police powers. I've written a paper about how this is actually an ideal use of both powers and a non-conflicting use of both powers where you can use the system that the states have set up for professional education and licensing to benefit the interstate commerce system to ensure that prescription medications go into the right hands but not the wrong ones. Good Samaritan and naloxone laws are those that provide that if someone is in the presence of an individual who has overdosed, then they are permitted under Good Samaritan laws to call 911 without fear of being prosecuted. Naloxone laws would provide access to a medication that can effectively reverse the effects of overdose from opioid medications. So if someone were to overdose on Vicodin, then an individual would be able to administer naloxone and bring the person out of the overdose and save the person's life. The policy question is whether those tools, that medication, should be available to anyone who hangs out with drug abusers or to family members who have individuals in their family with substance use disorders, or they should be available to first responders. And as part of my job, I work with the family members, the moms and dads and brothers and sisters and close friends of overdose decedents pretty much on a daily basis. And the consensus that I see among them is that it's very, very great for first responders to have access to naloxone. But this is not something that should be available just to anyone. It could potentially perpetuate a system of abuse, and it, according to these parents, could also lead to an overwhelming sense of uncontrollable guilt if you are not able to save the individual despite trying to administer the medication. So our position is typically that first responders are the best ones to have access to naloxone medications. Pill mill bills. This state legislation regulates pain clinics, makes sure, for example, that the pain clinics that are handing out so many opioid medications are actually owned by licensed practitioners, by physicians who have a state license to practice, that they are following certain reporting protocols, and it basically tries to attack the problems associated with those neon light pill mills that existed largely in Florida, also Tennessee, Georgia, Kentucky. And we are seeing that they are showing some effect. When I get to the progress slide, I'll show you that the numbers are showing that the conglomeration of these various state approaches to prescription drug abuse, which include the pill mill bills, are yielding results. Prescribing guidelines are questionable because typically, as an organization and as an individual, as a licensed professional, I favor the notion that a licensed professional must have discretion to practice his or her profession. Right? As attorneys, we don't want for our bar to come and say how we practice our profession with respect to a particular client. We want to follow our rules, but we want to be able to adjust our case strategy according to whatever the client's needs are. The same is the case with physicians and other healthcare practitioners. They need to be able to exercise discretion in choosing how to care for their particular patients. And so guidelines typically require that the practitioners adhere to certain protocols in treating people. But the guidelines have proven not to be as onerous as we had initially feared. The guidelines that we see out of Florida, for example, require a discussion of the risks of controlled substances, require a written treatment plan, meaning documentation in the medical record. That's not too much to ask. Written treatment agreements, not really an agreement under the law. It's really an awareness or education piece that one can use, that a physician can use with a patient to make him or her aware. So they call them patient-prescriber agreements, or the written controlled substance agreements. They don't have any force of legal effect, but they are an educational tool. And then referrals to specialists if the case shows that the person has substance use disorders, for example. And so, again, we are seeing responses to these things, and they are worthy of the attention of other states as they consider how to deal with prescription drug abuse. The corporate responses to prescription drug abuse have also been important. CLAD, as a part of its work, does bring corporate members, businesses, into its coalition. We take funding from various members of industry, including the pharmaceutical fields, drug treatment programs, as well as drug testing companies. Our funders are disclosed on our website. But the work that we do is vital because how can you take any sort of approach to dealing with a public health problem without pursuing private sector solutions? The market must play a role in reducing prescription drug abuse. It certainly plays a role in exacerbating prescription drug abuse. So we've been working with those responsible companies only. We only work with the companies that are developing safer medications, encouraging them to develop controlled substances that, as I described, might be less susceptible to certain forms of abuse. We're actually working with one startup company that has a concept for a medication that could outright prevent overdose. So it would be a bioactivated medication, and if there were too much in the system, it would cancel it all out. And if you think about how this could be utilized in society, how many kids in your middle school, I certainly experienced kids in my middle school who took too many aspirin as a plea for attention, signaling to their family members or to their teachers that there's a problem, too many Tylenol, not to mention too much cough syrup or other sorts of overdose scenarios that don't just involve controlled substances. The concept of a medication that could, in and of itself, prevent overdose is pretty fascinating. It's a ways off, probably 10 to 15 years, but that could change our society, right? So we need to encourage that sort of solution. We need to encourage investment in that, and in order for there to be investment in that, we need to see that the first round of abuse-deterrent medications are actually taking off, and that's another reason to support the STOP Act. Abuse-deterrent medications can also be developed for other treatment areas, not just pain, not just anxiety or the types of conditions that are treated with controlled substances. When you think about the underlying conditions, they can also be developed for addiction. So if you think about the medications that are available to treat addiction, and they're mainly methadone and buprenorphine. Buprenorphine can be provided in a physician's office, and methadone is typically provided in an opioid treatment program. But it would be possible to develop month-long injection of one of these medications or in an implant, so that the person wouldn't have to go as frequently to the physician's office and could instead focus on that psychotherapeutic aspect of treatment and recovery. So we want to continue to encourage the development of these medications, not just for the underlying conditions, but for the addiction itself. Since CLAD has been working with its coalition members to encourage private sector solutions to prescription drug abuse, we've seen that since 2008 there has been an entire industry that has just arisen, an entirely new field dedicated to testing for substance use disorders. So we know that drug testing has existed for years, and it's been used for forensics purposes, largely in law enforcement, in some cases in employment. That's not what I'm talking about. There is now a new industry for testing for substance use that is applicable to the health field. And so the part of the guidelines, for example, that we're seeing from states require this therapeutic substance use testing in order to be able to prescribe, and then periodically thereafter in order to be able to continue to prescribe controlled substances. There's testing that can identify whether or not one has pharmacogenetic risk for addiction. That's difficult because there are so many genes that can contribute to addiction. But pharmacogenetic testing is very, very useful for determining whether a particular medication will work for an individual. So think about this. You now, when you get a medication from your physician, you test it out. Call me back if it's not working in 3 days, or let's come back in 2 weeks and determine whether it's having your desired effect. That could potentially not even be necessary as genetic testing continues to evolve, and people can determine from the get-go whether or not a particular medication is appropriate to them. That's available now so that you can take the risk out of prescribing certain medications that one might not metabolize properly, right? So if you have methadone, for example, which is used to treat addiction, and someone is a slow metabolizer of that methadone, then continuing to provide the dosages could lead to a buildup and ultimate overdose. But if you know that the person has the gene that prevents that person from metabolizing properly, you can prevent that overdose. The problem is, in looking at these tests, there's confusion in the market as to whether or not this is for health-related purposes or for forensic law enforcement-oriented purposes. And there's a lawsuit now in Indiana. The ACLU is suing the Indiana Medical Board. The Indiana Medical Board has required testing for substance use disorders as part of its guidelines for safe prescribing. The ACLU is ignoring the fact that prescribers have a professional obligation to keep health-sensitive information confidential, and instead suing based on the notion that there's a Fourth Amendment violation of individuals' patients' rights under this pain clinic this prescriber guideline. So that's something that we'll be involved in moving forward, and that's something that you all need to understand as members of the legal community, whether you be on the criminal side or the policy side or anywhere in between. There is a difference between therapeutic testing for substance use and then the employment-related or criminal-related testing for drugs, right? Drug testing in its traditional sense. We'll hear more about that today from the perspective of drug courts. Locking devices, there are small companies that are developing devices that can be used to lock your medications, whether they be safes or locking caps. Those are great. Certainly someone with an addictive disorder could break those, get into the medications. They're very resourceful. But what they do more than anything is they create a conversation, they improve awareness. Insurers are providing data analysis and indicating to prescribers now when there might be a problem associated with the mix-up of medications or too many medications coming from different prescribers. Right? So they're issuing alerts. We also see on the opposite end of that the private sector insurers are also using their data to try to deny care and developing default rules against the use of certain medications, again, taking away the professional discretion. And so you've got to remain vigilant. For those of you who might be working with healthcare providers or in clinics with individuals who need to have access to healthcare, you should be aware that there are oftentimes default limits against people getting certain medications, and that you need to help them access those medications. That is more important now than ever, given that we've got the implementation of the Affordable Care Act combined with the Federal Equity Act, which I will also discuss. Now here's where I want to discuss the opportunistic responses to prescription drug abuse, because certainly We know that a lot needs to be done to deal with this problem, but some things don't need to be done. As an example, in Alameda County, California, there is now a new drug disposal tax that requires the manufacturers of controlled substances to pay a tax to the county so that it can pay for drug disposal. Well, first of all, that ignores the fact that as soon as the DEA promulgates the proper regulations, then we will have disposal that can occur in pharmacies, and it won't be necessary for government to provide funding for drug disposal. Surely there will be pharmacies that choose to do it as part of their community service and drawing people back into their pharmacies. But it also is creating a system whereby these multinational companies have to comply with the rules, the taxing authorities, and the various difficulties associated with meeting the requirements of local ordinances. That is not a system that is sustainable and that really makes sense. What we really know is that this is an opportunity for revenue generation at a time when counties and states are dealing with severe budget shortfalls. And so that is something that should not be replicated across other counties. Municipal lawsuits against manufacturers. There have been lawsuits in the past against manufacturers that have misbranded or improperly marketed their medications. That occurred with OxyContin, for example. But now we see that Chicago, Illinois is considering a tobacco-like lawsuit that would basically charge that there's some sort of conspiracy to get these medications into communities and get them addicted. That's absurd, frankly. And we have to remember that these medications are approved by the Food and Drug Administration. So, again, despite the fact that the anti-smoking litigation certainly did bring in a great deal of revenue for very important public health measures across numerous states, there shouldn't be a parallel drawn here with medications that have been approved by the Food and Drug Administration. Some people are trying to blame pharmaceutical advertising for the prescription drug abuse epidemic. But the drugs that are primarily abused can't be advertised. Controlled substance can't be advertised. So there's not really a tie. And there's no data that supports the notion that advertising has contributed to the abuse of medications. I've already mentioned that there are default rules now that undermine professional discretion and deny care with controlled substances and other sorts of medications, and that's largely for cost savings purposes. We know, of course, there are cost pressures on insurers regardless, but with the Affordable Care Act, requiring coverage of additional essential health benefits, the cost pressures are even greater. And so insurance companies are looking for any sort of opportunity to shave those costs, and it typically comes at the expense of people who have addictive disorders. States are also, just as a side note, states are also imposing limits on who can access certain medications. Some states have limits of 90 days on medication for the treatment of addiction. Federal law requires parity, meaning that there must be equivalence between what benefits are provided between the medical surgical area of healthcare and the mental health and addiction areas. And so we'll be making sure now that these types of laws that are inconsistent with that general premise of parity, even if they're not subject to the requirements of federal law under these two statutes, that the unfairness is exposed and that in the insurance companies that they actually be required to adhere to the federal requirements of parity. I'll discuss that in greater detail. So this is why I say we are seeing progress. And so we see all that's already been done at the federal, state, and corporate levels. And we also are starting now to see headlines that we are making progress toward reducing prescription drug abuse. Abuse-deterrent medications can reduce the risk of diversion, misuse, and abuse. That came out in July 2012, and that was about the reformulated version of OxyContin. Overdose deaths from opioids fell in Washington State by 27%. It's a headline from just January 28th of this year. Prescription drug deaths have fallen across Florida. That's where they had the very aggressive pill mill bill and prescriber guidelines. That came out last October. Kentucky sees a decline in drug overdose deaths, including prescription drug overdose. And Kentucky, like Ohio and West Virginia, has been at the epicenter of this epidemic. It also has been among the most aggressive states in dealing with it. So we might be able to emulate some of the responses from Kentucky in West Virginia and see the similar type of decline in overdose deaths. And the national survey coming out of the Substance Abuse and Mental Health Services Administration showed last September that levels of prescription drug abuse among young adults does continue to decline. But here's the difficult piece. We're seeing that there is an evolution of the epidemic. As these overdose deaths from prescription drug overdoses decrease, we're seeing an increase in the misuse of medications for the treatment of addiction, like buprenorphine, and the abuse of heroin. So we're losing an opportunity as we adjust the supply of controlled substances and other medications. We're missing the opportunity to refer people to treatment, to intervene in cases, and to get them into treatment and have them taper off under the direction of a medical professional, as opposed to trying to look for the streets for some sort of substance to stave off cravings, like buprenorphine, or heroin as a worst case. So this is now why CLAD as an organization, knowing that the recommendations that we started putting out there in 2008 are largely now widely being implemented, we're focusing on intervention and treatment, trying to now take advantage of the fact that there are supply reductions and get people now to reduce their own demand, right, to reduce the demand by intervening and providing treatment. Problem that with the heroin increase is that there has been lack of a corresponding reduce in demand. You're not getting to the people who are purchasing or otherwise accessing these medications and getting them to stop the substance use. They're just switching to other substances. And so we need to intervene and provide good treatment. The good treatment should be, if possible, with the non-opioids, the non-controlled substances, the safer medications, those that are formulated to be less susceptible to certain forms of abuse, like, for example, the physician-administered injection once a month, or the implant that otherwise doesn't require patient handling and can't be as easily diverted as pills. Neonatal abstinence syndrome is also a big problem, and this is one that, from our perspective, is quite complicating because it then draws into question the legality of reporting. When an individual in a healthcare setting becomes aware of substance use among an expectant mother, that individual is typically required in many states to report that to child welfare authorities. And so we've got this perverse scenario where individuals are being referred from the healthcare community, the healthcare setting, into the criminal justice setting. There was a case in Pennsylvania that just settled last year about a mom who lost custody of her newborn infant because she tested positive on a drug test. This was one of those forensic type of drug tests, which was not the new technologies that I was talking about. It was the old technology that's very, very imprecise. And so she tested positive for opioids. It was because she ate a poppy seed bagel. She lost custody of her child because she ate a poppy seed bagel. Obviously, she got the kid back and she was able to prove that she was not guilty of any sort of harm to her child. And she settled and probably, had an appropriate remedy given to her, but that should never occur. So lessons out of that, we've got to deal with, from a legal perspective, policy perspective, what to do about these reporting requirements so that we're not referring people from the health setting into the criminal justice setting. Refer from health to health, right? Make sure that they get the treatment that they need. Make sure that they are, appropriately taking care of themselves and their newborns or their fetuses, but don't send them to the criminal justice system or even the domestic relations system where they wind up losing custody or worse. That's also an important note for those of you who practice in the areas of forensic or areas of law that require forensic drug testing. Make sure that if ever one of your clients is found to be positive for a particular substance, that you require that there be a new test with one of these confirmatory, more quantitative, the new health-focused testing that I referred to, because otherwise, given the high rate of false negatives and false positives related to the old technology, you could have someone who is being accused and penalized for substance use when it was just really a faulty drug test. Stimulant and benzodiazepine use is also now problematic as part of this evolving epidemic. Stimulants are like Adderall and Ritalin. I'm sure you all are familiar with the concept of academic doping, not that you've done it, but that it is prevalent in competitive environments in high schools, even middle schools, and colleges. Right? That's where someone's cheating, basically cheating by using a medication that's not prescribed for him or her in order to be able to focus and to be able to study harder or to stay up late and do a paper and outperform someone who's not on a particular substance. At the university level, academic integrity policies need to be adjusted so that they reflect that this is cheating when someone is misusing or abusing a particular medication that was not prescribed for him or her. Right? And then the benzodiazepines are medications like Xanax. And this is very important to note also that as we deal with the issues of opioid abuse, those medications like hydrocodone and oxycodone, we have to deal with all controlled substances because Xanax was the substance most commonly found in the bodies of overdose decedents both in Georgia and in Kentucky. Right? So when someone overdoses, there's typically a lot of substances in the person's body. Right? But when you do an autopsy, in those states, it's been found that Xanax is the substance that's most commonly found. Typically, opioids are there too, and alcohol in many cases as well. But Xanax is the one that can typically tip people over the edge and lead to overdose death. So all of the policy measures that we're implementing related to opioids need to apply broadly to controlled substances, including these stimulants and benzodiazepines. So given the new resources that are available to prescribers and the fact that we are seeing aggressive prosecutions now, word's getting out that people are being prosecuted for murder, for rogue prescribing, there's now a self-sorting of prescribers that's going on, and this is a good thing. They're self-sorting themselves into the unwilling, those who are not willing to undertake the education necessary to prescribe correctly. They're dropping out. They're stopping prescribing, and that's a good thing. And then the uninformed are getting educated because they're taking advantage of these resources that are available through the federal risk evaluation and mitigation strategies, through the state requirements of prescriber education as part of their continuing education. And so that leaves the people who are the unlawful actors, right? So if there's anyone left who's uninformed, they can be dealt with by the medical boards. Unwilling, or they're not prescribing anymore. But those who are acting in an unlawful manner, they need to be prosecuted. And that group is perhaps remaining stagnant, not shrinking like the other cases. The people who are unwilling, they're dropping out. People who are uninformed, getting educated, or otherwise being referred to the medical board. And then those bad actors, they get prosecuted for second-degree murder. So this is going to continue to change, but it is up to the legal community to know who's uninformed and who's behaving in an unlawful manner so that you can refer certain cases to the medical board. It's not a criminal issue. It's an issue of this person not knowing better, not being trained well enough. And then prosecute the really bad cases so that you can make sure that you're not causing a chilling effect that prevents people from prescribing the medications that people need. Dirty docs, the rogue prescribers, these individuals who are in the unlawful category, they are continuing to do what they do. Been monitoring the case of Dr. Lisa Seng out of Los Angeles County, California. She's the one who said that if a patient of mine decides to take all of his controlled substance in the day, there's nothing I can do about it. Well, absolutely there is. And so she's being prosecuted now for second-degree murder. We don't know exactly how the case is going to turn out, but we're watching it very closely. Those rogue prescribers, they're going to continue to exist. Some of them are changing their tactics, though. So as part of the efforts to reduce the abuse of controlled substance, CLAD and other organizations have been saying we need to develop these newer medications. In addition to the abuse-deterrent opioids, for example, develop non-opioids. Develop pain medications and other medications for these conditions that currently require controlled substances that are not controlled substances. Develop the new medications that are not controlled substances. Right? So we've seen that there are new biologic medications that are available for the treatment of pain. Biologics are those that are created by biological processes, for example, vaccines and gene therapy. They're typically injected. Well, some of the exact same rogue prescribers, these dirty docs who have been found guilty of the rogue prescribing activities, they're now buying re-imported biologic products. So buying product that might be approved for use in the United States when appropriately labeled according to U.S. standards, but that is intended for the Turkish market, for example. So labeled for Turkey and in their language with all that's required by their regulatory authority. They're buying that medication, bringing it into the U.S. through illicit distribution channels that are oftentimes associated with mob activity. And then they're selling it and, in fact, administering it to patients who think it's the real deal. And so you've got potentially rotten product being injected into unwitting patients. This is a scenario that is even worse than what we see in the rogue prescribing, because typically with the rogue prescribing, there's the element of the individual who chooses to abuse, right, or chooses to misuse if the prescription is not right. But here, there's no element of intent, there's no element of knowledge for the individual who's being injected with these rotten biologics. So we've got to make sure that the solutions that we have to prescription drug abuse as we think about it for controlled substances will also deal with these new types of medications that are coming out, biologics included, to make sure that the dirty docs don't just adjust their tactics and harm patients in a different way. That, of course, requires also that we look at the pharmacies that are oftentimes diverting product that might be intended for nonprofit organizations or other products that might be in short supply. Look at the distributors as well. Gallant Pharmaceuticals, one of the images up there, that was located in my hometown of Arlington, Virginia. They were recently arrested, and staff is now in the course of plea agreements for exactly what I've described. They have been re-importing medications and selling them at a significant profit to unwitting consumers. I've got some of the faxes that they would send out to the physicians' offices. It's pretty funny because it is pretty hard to tell that they are not a real company selling real product. They claim it's real product, and it would be if it were properly labeled for the U.S. market and it hadn't eroded on the way here through the illicit distribution channel. Now, all of our efforts are being complicated by Maine. Maine is the first state now that is permitting the importation of medications from Canada. Canadian pharmacies also typically are, or oftentimes, are just Indian pharmacies that have a nice website that has a Canadian flag on it, or other sorts of rogue pharmacies by operators in other places besides Canada. So with Maine allowing the importation of these medications from different countries, we now see that our very, very closed system of distribution of medications is completely interrupted. And there's not a way for the manufacturers, the distributors, or the healthcare providers to know where a product came from, what happened to it, and it's problematic. To me, this is a direct parallel to what we see with the Supremacy Clause issues associated with marijuana legalization. Regardless of what you think about marijuana legalization in the states, federal law provides that marijuana is a controlled substance in C1, Category 1, Schedule 1, right? So it's illegal, no legitimate medical use. State laws are permitting the medical use, and in 2 states, even the recreational use of marijuana. And we've got this issue of the federal government not enforcing federal law. There's a Supremacy Clause question there. The same thing now is existent when we see Maine's law that's completely disregarding federal law and allowing operators in its state to bring in medications that come through an illicit distribution channel. What's going to happen? What happens to our federal notion of supremacy if we now have these systems where states are allowed to undermine federal law according to what is politically popular? We need to watch out, because I believe it's Arkansas that's now considering doing the exact same thing on gun control. So there's a slippery slope. Regardless of what you think of the underlying subject matter, there is a slippery slope that occurs when you undermine the supremacy of federal law. And that's something that you all are going to have to deal with one way or the other to find a fix so that we continue to have a system that works. So, nearing the end, I promise I will not continue for much longer, but I want to reiterate that it is essential that we reduce the demand for illicit substances. We reduce the demand for controlled substances and any other substances that people are utilizing in order to get high and that are leading to these substance use disorders. And that's going to require health-focused interventions. So the healthcare system needs to implement testing for SUDs and interventions like currently exists in the emergency department. There's a federal program, didn't make my list, I need to add it back to my list, of federal programs that are trying to deal with the issue of substance use. And this one is called Screenings and Brief Interventions and Referrals to Treatment. So the federal government gives money to allow emergency departments to determine when there is a problem associated with substance use, have a brief intervention, and make sure that the person has access to treatment resources. That needs to be expanded, not necessarily the federal grant, but that program of screening and then referring to treatment needs to be expanded to the primary care setting. So when you have your cholesterol checked, you have your substances checked to see whether you have any substance use disorder. Right? Emergency departments needs to be expanded, psychiatry, addiction, the surgical setting even. Physicians should know whether a person has a substance use disorder before conducting surgery, for example. But it also needs to expand to the educational, employment, and criminal justice systems. We see that it is expanding to part of the criminal justice system through drug courts. Drug courts are outstanding. We'll hear more about them from one of my colleagues today. But the key here is to make sure that there is not that confusion between what is punitive testing for drugs, old school drug testing, and therapeutic testing for substances of abuse, testing for substance use disorders. Right? So we need to refer from criminal justice system to healthcare, but not the other way around. Referrals of effective treatment. This is where I get to the Affordable Care Act. The Affordable Care Act, combined with the Federal Equity Act, also known as parity, they are, starting now, going to change the fields of mental health and substance use treatment if we, as attorneys, do our jobs. And we, as attorneys, have to do our jobs to make sure that these laws are properly enforced. So, the Affordable Care Act, you've probably heard of the essential health benefits, that certain plans, a great deal of plans, have to provide certain levels of coverage. Those 10 categories of coverage that must be provided under essential health benefits include mental health and substance use disorders. Right? So a number of new plans have to have coverage for mental health and substance use disorders. Now, combine that with the federal law known as the Equity Act. It's the Mental Health Parity and Addiction Equity Act. That provides that these treatments need to be provided through insurance companies on parity with the treatments provided for medical and surgical care. So if a person is permitted to do a cholesterol check every time he or she goes to the physician's office for a checkup every 6 months, then that person is, by matter of federal law on these applicable plans, permitted to have a substance use check. Right? If that person is not limited to 90 days worth of medication for diabetes, that person should not be limited to 90 days worth of medication for addiction. Right? So there are direct parallels that you can look to in these plans, these insurance plans, and other sorts of chronic diseases. And if it's not parallel in terms of the benefit for addiction or mental health being the same as surgical or medical, then that's a violation of federal law, likely, depending on which plan it is. But most plans, it's a violation of federal law. And it's your jobs, be advocates for the patients, to work with your healthcare provider clients to make sure that people have access to this care. This will, if it's appropriately enforced by attorneys, change the face of treatment for mental health and behavioral disorders. So I encourage you to look more into the Affordable Care Act, to the Equity Act, watch the work that we're doing through CLAD, and become involved to make sure that what is intended under federal law becomes reality. So this is where I ask you to become involved to deal with this issue, to help us. I think I'm the only attorney that I'm aware of who's dealing with this issue from so many legal perspectives, but I certainly need help. I've got a colleague who works with me in my office. We've done a number of journal articles, and we continue to monitor all the things that you've seen in my presentation, but I'm one guy, and I can only do so much, and we're at a point where I need help. Our organization needs help. Certainly there's like the National Alliance for Model State Drug Laws. They do one thing. They can be a great resource. We don't have to do everything. We can draw on the resources of these other organizations. They don't have to be legal organizations. We've worked very closely with the American Academy of Addiction Medicine, American Society of Addiction Medicine, American Academy of Pain Medicine. The work is being done. It just needs to be supported by attorneys. It needs to be followed through. We need to make sure that we do our part to support those other coalition members. And so the things that we need for you to do to evaluate what's going on, largely in the states, adjust for the new trends, like I talked about, with biologics now being injected into people who have no idea. They've come in from rotten chain of supply from foreign countries. being injected into unwitting patients. We need to adjust our prescriber education rules, for example, to make sure that the mandatory prescriber education at the state level includes knowledge about the gray market. This is what's called the gray market for pharmaceuticals. We need to expand those that are successful into other states and continue to adjust, like, for example, with prescription monitoring programs. We have 49 states that have them now. It's time now for states to require their use, require physicians to check the prescription monitoring programs before prescribing and periodically thereafter. As I already mentioned, collaborate with licensing boards so you can distinguish between those unwilling and the unknowing and the unlawful actors, so that the people who are unknowing can go to the licensing board and not take up the vital resources of prosecutors, and prosecutors focus on the bad actors. That includes the pharmacists who are diverting medications into the gray market, as well as the distributors who are running the gray markets. Support the transition to safer medications. So in addition to my encouraging the Senator to support the STOP Act with the Senate version of the bill, you all should also encourage the Senator Manchin, to support and, in fact, introduce the STOP Act in the Senate at the federal level. Enforce the ACA and Equity Act to provide interventions and effective treatment. This is what I just hammered on so hard. Make sure that federal law is appropriately implemented and enforced so that people who have mental health and substance use disorders get the care that they are now entitled to under their insurance plans according to federal law. Refer from the criminal justice systems to the healthcare and not vice versa. We have to deal with the notion of mandatory reporting that gets people into trouble, gets custody taken away, and winds people up in the criminal justice system when they went to a healthcare provider to ensure that their health, or even the health of their fetus, was properly taken care of. Right? So we need to deal with these sorts of issues, the mandatory reporting, in a way that sends people for health interventions, not domestic relations or otherwise criminal justice interventions. There is a limit that restricts how many patients a person can treat with medications for addiction. That needs to be lifted. Federal law currently provides that a provider of addiction treatment can only treat 30 patients with a buprenorphine medication in the first year and then 100 patients thereafter. That's ridiculous. Where else is the number of patients limited, and why? Certainly where the pain medications that are actually being diverted and causing much of our problems associated with prescription drug abuse. There's no limit on how many people a person can prescribe those medications. Why should there be a limit on the number of people who can be prescribed medications to treat the addictions to those medications? That law needs to be fixed. That can be done through HHS regulation. And then impose the state drug importation laws, regardless of what you think of the marijuana issue, regardless of what you think should be the case with respect to Maine. If you want to allow for importation, you've got to do it at the federal level. This is basic interstate commerce. If there were ever any issue of interstate commerce, it's this one. It's protecting the nation's supply chain from pharmaceuticals that are not properly regulated by our regulatory authority, the Food and Drug Administration. And so we need to make sure that states continue to do what they need to do with their plenary police powers, but the federal government do what it needs to do on interstate commerce. And so that requires that if you want to allow for importation from other countries, do it at the federal level, but don't allow Maine and other states to do it to undermine our system of supremacy of federal law. So I would like to make sure to, again, thank West Virginia University College of Law and the Law Review. All of you have been tremendously welcoming and absolute professionals, and specifically Patrick Callahan, who has been a superstar in putting this together. Excellent in terms of communication and absolute professional. Thank you, Patrick, for your work. And everyone has benefited from Patrick's work today. I would like for you to connect with me on Twitter. CLAD is also on Twitter, and LinkedIn. Please connect with me on LinkedIn. I would be interested in knowing whether any of you is working on the issue of prescription drug abuse. If you're interested, please contact me, and I can connect you with potential organizations that might be in need of attorneys, or help you with a job search. Eager to help in whatever way I can, especially if you're interested in dealing with prescription drug abuse. These are two of the papers that I mentioned that you might be interested in. Active Verification and Vigilance discusses the need for prescribers to take certain precautions to prevent prescription drug abuse. And then the Best of Both Worlds article is that state plenary police powers versus interstate commerce paper and how you can apply them to both of them together to reduce prescription drug abuse. So if you have any questions, I'll be pleased to take them. And thank you again for the opportunity to be here.
Thank you very much, Michael. What we're going to do, we have an adjustment in the schedule this morning because Professor Osnes, our next speaker, was unable to make it due to our common refrain, the weather. He's actually stuck in Philadelphia, so he cannot make it here today. What we're going to do instead is actually have a Q&A session this morning and in the afternoon. And what I'd like to do is actually introduce the rest of our speakers and invite them to come up and have a seat so we can have a broader range of knowledge with us while we discuss some questions we may have from Michael's remarks. So while you come up and have a seat, I'll introduce you both. So to the right of Mr. Barnes, we will have Adam Allen, who joins us from Florida. He's probably horrified by the situation going on outside right now, but he made it here, and we're grateful for that. He is a federal public defender and has been working in criminal defense litigation for 19 years, but has been working as a assistant federal public defender since 2000 with the Middle District of Florida in Tampa Bay. So he brings us an interesting perspective from the law enforcement side on the side of the defense side of that. And we also have Robert McKinney, who is counsel to the West Virginia Adult and Juvenile Drug Courts. His work he actually happily has roots in West Virginia, which we like very much, that he is from here. We like a little less that he went to Marshall. But that's okay, we'll forgive him. And we'll also forgive him for not coming to WVU. He went to Wake Forest University School of Law. But, we forgive him just barely, but we do. And he's practiced law for 17 years in private practice before taking on this important role with the West Virginia drug courts. So he has an interesting perspective as well. And I hope that based on the breadth of the discussion that we've already had, there probably are a lot of questions, and I suspect any one of our panelists can field them. So whatever comes to mind, feel free to ask, and we'll get those questions answered for you.
Anybody with questions who wants to just kind of come over here? Appreciate all of you being here. I'm glad we got you here safely. I wish Professor Osnes could be with us, but he's in Philadelphia, hopefully watching online. This kind of goes to all of you, particularly to some of the points Michael made. But some of the legislative proposals that are currently out there, they seem pretty basic. We're talking about monitoring programs, education campaigns for prescribers and for the public. And I'm wondering, I guess I have two questions there. On the one hand, why are we not able to advance some of those solutions through our political process at both the state level and the federal level? So is this a partisan issue in that sense? And on the second part, why are our regulatory agencies not able to act on their own? Is it a case of some of the special interests that Senator Manchin talked about? Are they applying pressure at that level as well? So I'd be interested to hear your thoughts on that. Thank you.
Well, I'll discuss that from two perspectives, the public awareness and the prescriber education or professional education. I think that a primary reason why we're not seeing those sorts of public awareness bills go through is budgetary. And frankly, my opinion is that that's not an appropriate use of government funding when we got people dying. We can have nonprofit organizations and others who can educate people about the issues of prescription drug abuse. That's actually a really great use of corporate money, for example. But on the issue of professional education, yes, there is a great deal of pushback at the federal and the state level. Prescription monitoring programs, the one state that does not have a prescription monitoring program besides D.C. Is because of an extremely right-wing legislator who refuses to allow it to go through in Missouri, and he's concerned about privacy. And there have been some privacy issues with prescription monitoring programs in our state of Virginia, and they have not had a significant impact, and certainly the benefits outweigh the risks. So the reasons that a lot of these things are not going through, I think, are not partisan. They might be in some instances budgetary, but on a whole, I think it's that people don't know what to do. There's not a strong enough push, and that we really need to start applying the pressure so that we can get these things through.
Living in a state that is the hub, apparently, where everybody comes to buy prescription drugs from the pain mills. There's been a lot of activity in our state to regulate these doctors, these road doctors. There's been little to nothing done to address the people who are getting the pills, the people with the addictions. From treatment, a lot of that is budgetary, and a lot of that is, at least for my clientele, it's a group of individuals that don't have a voice in society or that people really care about. If they're being prosecuted and they're being sent to prison, everybody seems to be okay with that. What it fails to acknowledge is that when you have an addiction, putting you in prison doesn't solve the addiction problem. So what you have is we're incarcerating people with addictions for long periods of time. They come out of prison, they're in a worse situation than they were before they went to prison because whatever support staff they had, if any, is gone given their length of incarceration. And they're coming out into society with the same addictions and the same problems that really aren't being addressed. And from my perspective, the group of individuals that I'm representing that have these problems simply don't have a voice, and really people don't care enough to pass legislation to do that. It's easier when we become in tight budgetary times to cut programs, to cut residential treatment for people that are on pretrial supervision. That seems to be the solution, is to incarcerate and to not treat, which really isn't solving the problem at all.
At the state level, and I'm an attorney with the court, not the legislature, but obviously we watch closely what the legislature is doing and what's pending with the legislature. There does seem to be a significant amount of will on the part of West Virginia state legislators to address various drug problems. There seems to be a lot of difficulty reaching exact agreement on how to approach this. I know right now that's sort of being exemplified by some competing approaches, how to address restricting access to the constituent components of methamphetamine production. Some legislators want to make all Sudafed products a prescription product. Some want to do a registry for people who have had a conviction before rather than impose a blanket requirement for everyone in the population. And that seems to happen a lot. There seem to be various competing approaches. I would say that some of the issues that Mr. Allen is pointing out are issues we are trying to address in West Virginia. We have evolved the drug court system that I'll be talking about after lunch. That is a system that is trying to do everything it can to take those appropriate addicted persons, and in the case of juveniles, early substance abusers, and deal with their problems through appropriate treatment with community supervised accountability outside of an incarceration context. It's a program that's still being rolled out geographically. But as far as programmatically, we've come a long way in West Virginia in a relatively short period of time, particularly given the last thing I would say is a challenge is just community education. To get the politicians and the legislators to get behind something, they have to know it's not going to be something that will present them with a serious threat. And if the public doesn't understand the nature of addiction as a disease, then that becomes very difficult to do. And that's one thing we always try to focus on. We certainly don't ignore the fact that we are in the criminal justice system, and the people who've committed crimes, there has to be some level of moral component to that. Their punishment can't be completely divorced from that system. But for people whose crimes are driven by addiction, the drug court system has evolved to focus on treatment.
Just a quick addition that your answer also raises the issue associated with prison contracts that require a minimum census so that there's an incentive to send people to the criminal justice system instead of through the treatment system, and that absolutely needs to be changed. Is that the case in Florida?
It is. I mean, I'm mostly dealing in the federal system. We do have drug courts in the state of Florida. In fact, they originated in the state of Florida. Our state system does a much better job than the federal system is doing nationally to address these issues. But there is incentive for people to be in prison. Most prisons, all prisons, their budgets are based on the number of people that are in prison. So their incentive is to not early release. Their incentive is to incarcerate. And so it's kind of a cottage industry of incarceration, and it's just a never-ending sort of cycle that you see. The clients that we represent that end up in the federal system, typically they're not first-time offenders, but you see when you learn about your client the history of addiction that they've had from a very, very early age. Very few of them have ever been provided any treatment opportunities. A lot of that is socioeconomic. They don't have insurance. Their parents didn't have insurance. Their parents were addicts. They're in foster homes. They're this class of individuals that don't have the resources. The first time they're ever provided any level of treatment is in the criminal justice system. When you have a drug court program, it's fabulous because they understand the process of rehabilitation and drug treatment and that you're going to relapse. When you're not in a drug court program and you're on supervision and you test positive, the solution is to send you to jail. And then you never come back to the counselor and you never figure out, why did I use on that day? What triggered me to relapse into that? So what we kind of see in the system that I currently work in, which is the system of every federal court around the country, is just this cycle of individuals coming in and out of prison without any solution to what's causing them to reoffend, because it's the addiction that's just not being addressed.
Professor Fouché.
Thanks very much, Michael. I enjoyed your talk. One of the things that, and particularly in the criminal justice context, you talked about the use of second-degree murder charges for those who are prescribing or making the drugs available. And then you talked separately about the need for the Rockefeller-Ray Hall Act and mandatory education. And I'm curious how those two things work together, because it seems to me to say that second-degree murder is appropriate because everybody knows, and then one of the most critical things we could do is require education, don't necessarily seem consistent. Though it would seem like it would be a good push for the Rockefeller-Ray Hall, though, would be that with that second-degree murder charges, it would seem a lot easier and perhaps a greater deterrent. I'm just curious your thoughts on that.
Right. I apologize for the confusion there. It was largely, my suggestion was that as we see states, I think there are 9 states now that require education of professionals on safe prescribing and abuse detection and referrals to treatment. As those laws take effect and are expanded to other states, that knowledge increases and the prosecutors are justified in charging with second-degree murder. But it also looks to the individual case and whether or not the individual had knowledge. And in the case of Lisa Seng in California, she had already had about 3 or 4 individuals in her practice die from overdoses when she prescribed to the individuals who are now the subject of the charges against her. So in that case, regardless of whether or not she had to have education under the licensing rules, she had knowledge, and a second-degree murder charge is appropriate for her.
Hi, thank you guys all for being here. It's been really informative and great. Mr. Barnes, you talked a little bit about this point, but I was interested to get a little input on how, if at all, you all think the push towards the legalization of marijuana might affect the issue of prescription drug abuse, maybe particularly in this state, but also maybe just as an overall principle.
I'll start first because I'm going to give a non-answer. The part of drug courts, we really don't take a position on whether marijuana should be legalized or not. The drug court system in West Virginia is a hybridized system. Most courts can be either just strict drug courts, or about half of ours are hybrid DUI courts. Our upshot is we're not a public health agency. We're the court, we deal with criminal justice issues, and our focus is to protect this public safety and to try and decrease recidivism by taking a population that's in the system and addressing why they're in the system in a way that makes more sense. If that person comes into the system because they're using or misusing a legal drug but have committed a crime, in a hybridized court where they take DUIs, you can still receive alcohol treatment. It's still something we can do in this system. I would imagine the same would be true were marijuana to be legalized either medically or recreationally. If, for whatever reason, your misuse of it at that point caused you to commit an offense and you were deemed to have a problem significant enough to merit drug court participation, we could still address that in drug court.
Your question's kind of open-ended, but I don't think if the question is the legalization of marijuana going to contribute to an increased use of prescription drug abuse, I would say the answer is no. At least from a perspective of the standpoint of the individuals that I see on a daily basis, which are people who are charged with criminal offenses who have addiction problems. These are individuals, I believe addiction is a disease. I think they have addictive personalities. If it's not pills, it's heroin. If it's not heroin, it's methamphetamine. If it's not methamphetamine, it's cocaine. It's a never-ending change of differing substances that they are using to either address mental health issues, to address situations that happen to them, early childhood sexual abuse or something of that nature, or dealing from a psychological standpoint through a self-medication. In my opinion, the legalization of marijuana is not going to increase or decrease, for that matter, the prescription pill problems that we have. That's not based on any studies, but it's just based on 19 years of seeing individuals with addictions and sort of what their backgrounds are and what caused them to be in the situations that they're in.
So my answer is yes, that it will increase prescription drug abuse. And so I'll give you 3 main points. With the legalization of marijuana, there is a perception that the harm of marijuana is lower, right? And so more people are willing to try it, more people will use. When more people use, then that reduces the resources that are available for interventions and treatment. With the greater supply, we know that there's greater use. We've already seen that in prescription drug abuse. When you reduce the supply, typically you need to get people into treatment or they'll shift, but with the greater supply, there's greater use. And with marijuana being a gateway drug, you're more willing when you're uninhibited or when you've had a positive experience with one illicit substance to try a different substance. But most importantly, as much as I have a libertarian streak, there is a problem associated with the marijuana legalization from a fiscal policy perspective. The tax revenues that would be generated from the legalization of the substance would not cover the costs associated to society with the use of the substance. So if you look at the numbers from the CDC and the cost of 2 other legal substances, tobacco and alcohol, right? And then you look at the collection of taxes. There are numbers with respect to alcohol from the Century Council, and the ratio is like 90% greater expenditure than revenues associated with their taxation. And so when you've got the greater expenditures of public resources going toward a different substance, the problems associated with alcohol, tobacco, and add on to that marijuana, then you don't have the resources available to treat prescription drug and other substance use. So yes, there will be an impact on the public health associated with the legalization of marijuana, and it will actually impact prescription drug abuse specifically.
So we don't have, you want to ask another, maybe we'll take one more and then we'll break for lunch. Does that sound good? I'm looking to my bosses here in the law review section.
Thank you again for being here today. I wanted to ask about, we heard a little bit about today about the disposal of controlled substances, and I find that that's an aspect of this curious. We talked about the drug take-back days and the possibility of having a pharmacy as a disposal location and even the Texas disposal tax. I was wondering if you could distinguish between, well, I understand in the larger scale, like confiscated large quantities might need more regulation on disposal, but in an individual capacity, a surgical patient who doesn't use all their pain medication or a family member who discovers illegal controlled substances in their house, what's the distinction between just disposing those like expired Advil by flushing them or turning them into a pharmacy? And can you highlight the goals and what that will achieve?
Sure. So the drug disposal programs are largely to prevent the diversion of the medications from medicine cabinets. But that argument from a policy perspective hasn't really been effective. What has been effective is the environmental argument that if you flush medications, that there is going to be a problem associated with depressed fish. You know, there was a study out of Sweden that with all the medications that were actually, it was the opposite. It was all the medications, like the antidepressant medications that were in a particular river from people having flushed, that these fish were very, very easygoing and ultimately were great subjects. They were prey. They became prey, and they were being eaten by their predators much more readily. So that has had its impact.
They didn't mind. It was okay.
Right, yes. So that has had its impact, you know, so there's a great environmental argument for not flushing. But if you think about the benefit of not flushing versus if you expire a medication by urinating, the medication is going to go into the water system anyway. It's typically not metabolized wholly. And so, 95% of it will go into the drinking water eventually, or the rivers or whatever eventually. So that's really not, the environmental issue is not great for policy in terms of making a difference, but it is great for public awareness and spurring action, right? But the real point of medication disposal is to get it out of the medicine cabinet so the kids don't get it, try it, get hooked, and ultimately have an abuse problem.
With that, we will take a break for lunch. We will reconvene at 1 o'clock. The schedule says 1:15, but we're going to shift things a little earlier to try to stay on schedule and give our speakers ample opportunity this afternoon to share their thoughts with us. So we'll see you back here at 1. Thanks. Is a West Virginian, and we're so glad that he's here with us today. So please join us.
Good afternoon. I'm thrilled to see so many of you back from lunch and looking much more awake than I generally look after lunch, so that's also good when I'm not speaking. This will keep me awake for that. It is true I am a West Virginian. My paternal grandfather was actually a coal miner in the rising at Blair Mountain. So it doesn't get much more West Virginian than that. Unfortunately, he passed when I was 2, so all I know is that it happened. I have no fun stories to tell. I also know defamation action obtains here. I am a Marshall graduate. I am a Huntington native and had long said that I would never go to Marshall. They couldn't pay me to go to Marshall, and then I got a scholarship and found out very soon they could pay me to go to Marshall. And I did not go to West Virginia University. My continual joke is that I think I am one of 20 attorneys who practice in West Virginia who did not go to West Virginia University. And it is a deep regret in my life, both for the lack of opportunity to get to know my brethren better and every month when I open my student loan bills from Wake Forest. So it is a wonderful school. I have had a number of wonderful experiences here in continuing legal education, doing research, and interacting with the school since I've been a practicing attorney. And that experience has reached its peak possibly today, and with the wonderful professional work that's been done by the staff of the Law Review, particularly Patrick Callahan, and by your administration in welcoming us here and putting this on despite significant challenges. As we speak of significant challenges, West Virginia is currently facing an unbelievably significant challenge in the way of drug abuse and addiction. These are two very telling statistics. There are others that are bad. Right now, West Virginia has the most overdose deaths per capita in the United States. And that number, at least insofar as the most recent figures I've seen, is still rising. The figure I saw is that it had increased sixfold between 1999 and 2010. Additionally, if you look at the other end of the life spectrum, there was a 2009 umbilical cord study done, 8 West Virginia hospitals. 1 in 5 infants had had an exposure to drugs. I think that included alcohol. A newer 2010 study in 1 hospital revealed it was 1 in 3. These are not sustainable numbers. What can't go on forever won't. And we have got to rise to this. And these numbers are indicative that traditional methodologies have not been sufficient to address this problem. That was a problem that, and a realization that occurred in Mr. Allen's home state in Florida. I believe it was 1989, the first adult drug court went into effect in, I believe it was Miami. And since then, they have been spreading throughout the nation as an innovative, holistic approach within the criminal justice system to address addicted offenders. In West Virginia, the very first drug court was a juvenile drug court that was formed in Cabell County in 1999 pursuant to a federal grant. Unfortunately, when the grant funding expired, so did that program largely. However, in, I think it was 2003, in the First Circuit in the Northern Panhandle, an adult drug court program began, and that began the growth of adult and juvenile drug courts as a more systematic approach in West Virginia. It experienced a lot of growth in 2010. There was a lot of expansion of the adult drug courts that year. And over the past few years, we've seen, I think, since the beginning of 2012, at least 5 new adult drug court programs have gone into effect. As of last year, talking about this is a problem West Virginia has to face. It is a problem that we can ill afford. As addiction continued to drive more offenders into the criminal system, it contributed to the increase in the incarcerated population of West Virginia. It certainly was not the only factor there, and many factors were addressed last year in a very large legislative effort. It was the governor's prison overcrowding bill, helped out by a justice reinvestment initiative. Drug courts were included, not in a large extent because the drug court statute already existed at that point, but a modification was made that by July 1st, 2016, every judicial circuit in West Virginia is required to participate in an adult drug court program. That will mean, in many cases, new counties will get their individual programs. Some counties will participate in regional programs. To our knowledge, we are the only state in the union that has mandated that the entire state receive drug court coverage. West Virginia, people frequently will say, and it dovetails with a lot of assumptions about West Virginia that are not without basis, that West Virginia would be resistant and West Virginia would not be open to an innovative treatment-based approach like this. But largely that has not been our experience. West Virginia has welcomed it to date. All of the drug court programs that we see in West Virginia are voluntary. The judges, the treatment professionals, with the exception of one person in each drug court, everyone donates their time and effort, and it's not a small amount of time, and certainly not a small amount of effort. The only person who is a full-time employee is the coordinator, who in our state is the drug court probation officer. And given that the work they do, that's certainly commensurate. They are working odd hours, weekends, evenings. What exactly is adult drug court? It is a specially designed court docket. It is not technically itself best understood as a court. It is better understood as a court-officiated program. The idea is to reduce recidivism and substance abuse among substance-abusing offenders and increase the likelihood of successful habilitation through early, continuous, and intense judicially supervised treatment, mandatory random drug testing, community supervision, use of appropriate sanctions, incentives, and other rehabilitative services guided by the 10 key components. The 10 key components are a set of guidelines that set forth the basic principles and values for drug courts that were developed primarily by the National Association of Drug Court Professionals and its research and publishing wing, the National Drug Court Institute. These are how you can't just slap the name drug court on a program and say it's a drug court. There are things that you have to do in order to qualify and to be understood to be a drug court properly. This is where the drug courts are now. As you'll see, we have kind of been surrounding West Virginia. The earliest programs were in the First Circuit in the Northern Panhandle. Almost immediately thereafter, that enormous regional drug court in blue that you see at the bottom of the state, centered in Mercer County, was developed, and Judge Swope is unbelievably proud, as he should be, of the work he's done then. The judges in the Northern Panhandle have also done outstanding work developing that, but one of the key personnel who was really helpful in developing all of that was one of the probation personnel. It was the Chief Probation Officer, Jim Lee, who was an early believer and an early evangelist for the idea of problem-solving courts in West Virginia. The most recent courts we've opened in West Virginia were Putnam, Marion, and Mason. In fact, Marion just completed their initial training session in the past week. We do have a plan that we will be able to initiate drug courts for the entirety of the state by the statutory deadline. And we're phasing them in 2 to 3 at a time. The 10 key components. U.S. Department of Justice identified these. They are actually made a statutory part of West Virginia's drug courts. The West Virginia Drug Court Statute is located at 6215.1. It is the entire Article 15 of Chapter 62, and it governs the principles of West Virginia drug courts. Another foundational document for West Virginia adult drug courts is an Adult Drug Court Policy and Procedures Manual that was promulgated just this year. It's the first time that we've had a uniform policy and procedures manual for the adult drug courts in West Virginia. These are the key facets of an adult drug court. This is how you know a program is legitimately an adult drug court. It is integrated. You are integrating alcohol and other drug treatment services with justice system processing. It is non-adversarial. We'll get into structure of the drug court and the specific entities that make up a drug court, but it includes and comprises the participation of both prosecution and defense attorneys. It seeks to identify early an appropriate drug court participant and get them into drug court as soon as possible. The empirical research nationally shows that recidivism is somewhat impacted if you take someone as soon as possible from arrest and get them into a drug court program. Even more positively impacted, however, by early identification and placement into a drug court program are system costs. That's how there are a lot of factors where drug courts produce great savings to your state's criminal justice system. One other point that I do want to make about saying you identify them early, however. Adult drug courts are, and I'll probably talk about this later when we're talking about targeting, but adult drug courts are addiction courts. An adult drug court is not for someone who's just gotten picked up with a dime bag of marijuana. It's not for somebody who just has minor abuse issues. Adult drug courts are intended for addicts. They were specifically developed because the criminal justice system had a population that nothing in the traditional toolbox was working. So they took this population that's defined as high risk, high need, and we'll talk about what exactly that means, and developed this program specifically targeted to such individuals. It is intended for addicts, and that is actually a key difference between adult and juvenile drug courts. Treatment and rehabilitation services. Spoken earlier, and I'll continue to speak, drug courts are a treatment program. They are a treatment program that seek to make sure that accountability is present. They are a treatment program that is intended only for offenders in the criminal justice system. And it does not obviate the need for some sort of social judgment on the part of someone who's broken the law, but we put that aside in drug court. I'm not saying that that's not a significant factor for the criminal justice system, but when someone is accepted in a drug court, the decision is we are making a decision to focus on treatment. Abstinence is monitored by frequent alcohol and other drug testing, primarily other drug testing, though alcohol is regularly tested. The rule that is in place for West Virginia's drug courts is that drug testing must occur no fewer than 2 times per week for every participant, and that all drug tests have to be frequent, random, and observed. Frequency is met by the 2 times weekly. That is the national standard that has evolved. Random, that is intended to mean that everyone in drug court has a 1 in 7 chance every day of getting a drug test. And observed means what it says. Somebody involved in the drug court program is with them when administering the drug test. If you're not doing that, then one thing you will find out about addicts are extremely good at serving their addictions. They are capable of unbelievable intelligence, resourcefulness, will when it comes in service of addiction. And they will figure out ways to beat your drug test. They will know your drug tests better than most of your officers, unless your officers are incredibly well trained, which is something we try and stay on top of. Ongoing judicial interaction coordinated strategy governs drug court responses to participants' compliance. This is primarily the incentive and sanction function of drug courts. Drug courts are best understood as a behavior modification treatment program. The incentives are what people want to focus on. All of the national research, all of the training we give out is that we should be focusing as much as you possibly can on incentives. Look for reasons to incentivize compliance. But sanctions are an essential part, that you have to have something in place to disincentivize noncompliance. Ongoing judicial interaction means that there is a judge. Each drug court, probably a drug court team is best understood as the group of multidisciplinary professionals who are involved either in the criminal justice system or in substance abuse and treatment. That team has a leader, basically a commanding officer and a sergeant, if you'll indulge me in a military analogy. The commanding officer is the judge. The judge is the final authority and the final word on most of the decisions in drug court has to be. But the person who is most responsible for running the drug court, for the day-to-day operations, for knowing what's going on with the participants, and for making sure that all the various members of the drug court team have the information they need to make the appropriate decisions, is the drug court probation officer. That's the term I'm going to use because it's the person who is responsible for that in West Virginia. If you look at literature or information from outside West Virginia, that position is generally referred to as a drug court coordinator. Monitoring and evaluation measure the achievement of program goals and gauge effectiveness. This is required also statutorily in West Virginia. There are certain reporting requirements we have to meet, and we are evolving a data management system that will better enable us to meet them. Right now, we have the information we need barely. We have put together a database that is, we've had people from out of state come and look at it. It is one of the better functioning databases for its purpose, not just for drug court, but for offender case management generally. And we are rolling that out now, and it should be an unbelievably important factor in refining and developing our procedures and practices going forward. We are also involved in actual evaluations. The court was successful in the last year of applying for a BJA, Bureau of Justice Assistance, federal grant. Part of that will be a 2-year evaluation of West Virginia's adult drug court by the National Center for State Courts. That will give us an empirical, verified, objective report and analysis and summary of how West Virginia is doing in terms of both its procedures and its outcomes. Continuing interdisciplinary education. Our office is involved in making sure all of our people have the appropriate and up-to-date training. We provide information, we host conferences, we go to individual courts and provide training and assistance as needed. And forging partnerships among drug courts, public agencies, and community-based organizations. That's sort of one of the other jobs that the judge and the ADCPO, the Adult Drug Court Probation Officer, tend to share. They have to be the ambassadors for the drug court into the community at large. One interesting factor with West Virginia that we've discovered, the national standards, the national rules, the national research, it's all good. We adhere to it, we follow it, but by and large, it's for urban populations. It is for populations that are not as rural, not as poor, not as geographically spread out as our populations in West Virginia. That has been a significant challenge for providing services. Transportation is a recurring issue in all of our courts. For this reason, it is essential that there be developed community support for drug court programs. Drug court programs will need assistance, will need people to help, will need incentives. I mean, one of the most common incentives you'll see has to do with gift certificates. Businesses are providing those gift certificates. Some of them are providing, I know in one of our drug courts, there is a local community and technical college that's providing free coursework, career development for our drug court participants. Those are the sort of partnerships you need in the community for these programs to work. Drug court practices. We talked about early identification and referral and judicial process. Substance abuse treatment is central. Frequent drug tests, collaborative team approach, judicial supervision. Not just supervision also, and I'll get into this more, but the judge has a key role to play in interacting with the drug court participants. Intermediate sanctions. One thing that we were talking about earlier is there must be in drug court, at least in the early phases, a tolerance for relapse. Again, it is an addict court. You cannot have recovery 99.9 recurring % of the time without relapse. When we first started out, there were a lot of judges who wanted to do this, but whose initial approach was, well, we're going to be zero tolerance. First hot test, you're out. Doesn't work. Can't work. And those judges were the first to identify that issue and move the practices and procedures forward appropriately. Case management is an interactive, holistic group approach to making sure you're meeting the criminogenic needs and other responsivity needs of the participants. Second chances, and at the bottom, not a build your own court. The adult drug courts in West Virginia started out growing up individually, but now they are part of a system administered by the Supreme Court. And we work together with the local programs so they can identify their population and their needs, but that they can provide a consistent system so that we can find out what's working, what can be applied in other areas of the state. As I said, West Virginia Code 62151 is the Drug Offender Accountability and Treatment Act that governs how adult drug courts are administered in West Virginia. It's not micromanagement. It doesn't get down in the weeds, but it does give a good framework. When I here in a little bit, I'll show you the entirety of the statutes for juvenile drug courts on one slide. One factor that a couple of people have asked me about already is, when do people go into drug court? What point? They can go in as soon as they're arrested, really. That seldom happens. You have to have a referral source that's willing to refer them at that point, and some courts do and some courts don't. Generally speaking, that referral source is going to be the law enforcement community. And while no one is a bigger supporter of drug courts than law enforcement personnel who have bought in, getting that buy-in can be one of the most challenging aspects of developing a drug court. It's not consistent with their training, temperament, and background. But all the effort it takes to work with law enforcement pays off 1,000-fold, because they will be the greatest champions for your drug court once they see how it works. It can be, but by statute, it can be pre-adjudicatory or post-adjudicatory. There are some programs that have made the decision they will be solely post-adjudicatory. That's their decision. That the statute leaves that option open to them, and we will not micromanage courts on decisions like that. The local courts have to have the ability, within the parameters that are set in the statute, to tailor their programs to the needs of their community. Morgantown is going to have different needs than Welch. The basic organization structure is really two groups make up an adult drug court: the treatment team and the local advisory committee. The treatment team is the group that meets every week, talks about the participants, talks about how they're doing, talks about whether there's been any kind of infraction or whether they've had a good week, decides what incentive or sanction to award, if any, and then goes into court for the drug court hearing with the participants. That's going to be made up. Its makeup is dictated by the statute. It's going to include judge, probation officer, usually the chief probation officer, prosecutor representation, defense bar representation, DHHR or day report center representation, treatment providers, and other people who can be selected by the team. The local advisory committee is more of sort of a board of directors. They aren't as entitled to the specific confidential information about the participants. They don't govern what's going on with the participants. They are the link between the larger community and the drug court. They are representatives of the community who make sure the drug court is doing what it needs to do to serve the community's needs, and they are there to try and, on behalf of the drug court, speak to the community and access resources. All drug courts are administered by the Supreme Court's Division of Probation Services. Juvenile drug courts have been with the Division of Probation Services for several years. Adult drug courts only came under the division at the beginning of 2012. That was when I came to the court. Who is an appropriate candidate for adult drug court? An adult person charged with a criminal offense, punishable by incarceration, where the offense is either a drug-related offense or an offense in which substance abuse was a motivating factor. However, there are exclusionary factors. If the underlying offense involves felony crime of violence, unless there is a specific programmatic curriculum available designed to meet the needs of violent offenders, that's going to disqualify them. If the underlying offense requires registration as a sex offender, or if there are priors that meet either of those conditions, those people are excluded from drug court participation. That's statutory. There are also local programs can come up with their own reasons to exclude. A number of them will not admit confidential informants for pretty good reason. A number of them are, one issue that you have to be very careful of is admitting drug court participants who have distribution charges. It can be a worthwhile thing to do. It is certainly not forbidden under statute or Supreme Court policy. But the concern is if you have someone who's a career criminal selling drugs, you do not want to put them in a room with a lot of drug addicts. That's not a recipe for success. Eligibility limitations, other guidelines. They have to be willing to cooperate and work with the program. All drug court participation is voluntary. Sometimes voluntary is a spectrum, but no one has to stay in if they want to leave. There can be consequences to leaving, particularly if you're coming in post-adjudication. But you have to be a West Virginia resident. You're being supervised by a probation officer. Once you step outside of, if you're not a West Virginia resident, that probation officer's jurisdiction to conduct searches or perform an arrest become non-existent. So it's best to keep people in West Virginia. Have to be an adult. Have to be able to understand and apply program requirements. There must be amenable treatment available. This touches on an issue very significant to this symposium. One issue that comes up a lot to do with West Virginia drug courts is whether a participant can be in medicated assisted treatment, which is to say methadone maintenance, Suboxone, while participating in drug court. The state policy is that they can. In fact, state policy is you cannot, as a matter of your local court, specifically forbid people who are on MAT from participating in your court because that would be violative in our reading of the Americans with Disabilities Act. However, not every court in the state has access to a MAT program that they can integrate into their court services. And the court has to bend to reality. If they don't have that treatment available, if someone's on MAT or wants to be on MAT or needs to be on MAT, but in that geographic area that they don't have access to it, then that's likely going to make it impossible for them to participate in drug court in that area. And must be charged with a misdemeanor or felony offense, including DUI. Not all courts are hybrid DUI courts, but at least half the ones in West Virginia are. There has to be written agreement with consent of prosecution. In adult drug court, two people have veto authority over whether someone comes into drug court. The drug court judge and the prosecuting. If either person says no, then that person can't come in. You have to have your referral form. Drug court judge makes the final determination, but if you don't get the signature from the prosecutor, they can't come in either. And statutorily, it is written into the drug court statute that there is no right to be in drug court. And indeed, geographically, we can't do that right now. The way someone is determined to be in drug court, high risk and high need. Risk has to do with your likelihood of offending if you are only receiving traditional criminal justice responses. Need has to do with your level of addiction. You have to be at least an extreme substance user or an actual diagnosed addict. And you have to be someone with a very high likelihood of reoffending. And this is, when I read a lot of the literature, I see two basic sources of criticism for drug courts. One is a traditional, punitive, incarcerative approach. And I believe we have a factual response to that we've gone over several times. But there are a lot of people who seem to attack from the other side, that drug courts are too punitive, that they take people that they shouldn't take. If a drug court is taking people who are not addicts, I agree with that criticism. That's not what they're designed for. That's not what they're intended for. That's not what our policies dictate. So I think that that criticism is not a criticism of drug courts in theory, but in practice, hopefully other places in West Virginia. Referral to drug court is not acceptance. A referral can be made from many sources in the community: law enforcement, probation officer, attorney, judges. They can all make the referral. Sometimes just family members or friends can make the referral. Referral goes to the drug court. They're screened for legal eligibility, whether they meet the criteria or whether there are any disqualifying factors, and then screened clinically, whether they meet the high-risk, high-need criteria. That's done with an objective instrument called the LSCMI. Prescription drug abuse in West Virginia. West Virginia has 17 drug court programs covering 33 counties. Prescription opioids are the single most commonly abused drug in our rural adult drug courts, but that's 15 of 17. It's number 2 in the other 2. Prescription drugs are probably the most significant problem, at least that we're seeing in the drug courts. And as I said, statewide, all of our drug court probation officers they're continuing to see an increase in prescription drug abuse among the referrals. By law, the program is required to last 1 year, but your time in drug court can't exceed the maximum sentence for your underlying offense. Judicial supervision, this is where the judge gets involved. Participants have to appear before the judge a minimum once a week. The program is divided into 3 phases. Initial phase is stabilization. Second phase is primarily a treatment and rehabilitation phase. Third phase is trying to transition them out of drug court and into the community. Also, all courts have at some level of aftercare being provided, though we're trying to work up a more consistent program and system for that right now, available to people once they do graduate. But the judge's participation is key. This is true for both adult and juvenile drug courts. The consistent finding we get from the information we get from NADCP, NDCI, the other national research, is that one of the most meaningful incentives or sanctions that the participants receive is either criticism or praise from the bench. The recommendation as a best practice is that at each hearing, the judge spends 3 minutes with each participant who's there for that hearing, talking to them about their week, what have you done, if they've had an infraction, going through why it happened, why didn't you incorporate this from your treatment, how would you address it next time, do you understand that this was a problem, do you deny that you did this? They have to have the opportunity to present their own side of things as a simple matter of due process. Phase 2, how often they're in front of the judge, becomes more of a case-by-case determination. And also the same for Phase 3. Community supervision is what the probation officer does, assisted with the case manager. They're monitoring. They're talking to them. In Phase 1, they're supposed to at least talk to them daily. And that can reduce over time. They're supposed to see them in person at least weekly in Phase 1. And they're going to be conducting home visits. They're going to be seeing them at least twice a week for drug testing. They're going to, if they have a job, conduct work visits. This is one of the reasons why it's perfect, why the drug court probation officers, while paid, are probably underpaid. Unfortunately, the nature of addiction is that it does not take evenings or holidays off or weekends. In fact, it tends to kick in rather extremely on those times. So those become very busy times for the probation officers. And one of the key points we're talking about, the incentive and sanction factor of drug court is also, along with drug testing, is one of the key distinguishing factors of drug court as a means of addressing addiction in offending populations. It is intended to reinforce good behavior at least as much and hopefully more than it is intended to penalize bad behavior. And it's not, and penalizing is even drawing a bit heavy. The idea is not to punish at all. It's entirely trying to modify behavior. Doug Marlowe is a national researcher and writer in this topic. He's a JD and a PhD. He came and spoke at our drug court conference last year, and the analogy he made was very telling, was that we are trying to learn from the drug how to get people off of the drug. How does the drug condition people to use it? Well, it gives you a positive incentive. When you use it, you feel good every time. So when participants comply, give them an incentive every time. That is a tough standard to hit, but that's what we're trying to encourage, why we're trying to stress rewarding good behavior. You won't catch all of it, so you have to be especially sure you note all of it that you do catch. Over time, the role of incentives will diminish. You'll stretch them out. You won't get them as often, again, like the drug itself. But the role of sanctions will become more important because they've built up the ability to adhere to the program better. They can maintain sobriety as they go through the program if they're working their treatment. And at that point, relapse has become a more significant problem and more worthy of significant sanction. These are the graduation results that were as of December 2012. We had 420 participants who graduated, and our graduation rate in the courts since 2003 was 52.23%. Recidivism, which is defined by statute as a subsequent charge for a crime that, basically a felony. Subsequent felony charge is how recidivism is defined in the drug court statute. The numbers that we had, looking at all the participants over the years 2011, 2012, we only had 9.4% who reoffended during that period. Now, this is not a recidivism rate verified, run through a formal study. That we're working on that now with under the BJA grant. This is a raw number, but it's a good raw number. And it's better than the numbers we're seeing in the rest of the system, where the rate of recidivism for traditionally incarcerated just adult offenders is 30.04%. And at the national level, if you're a substance abusing offender, the rate's more like 75 to 80%. Finally, the cost savings. This is an estimated average. I will tell you, if to the extent that that estimate is inaccurate, it's inaccurate high. That's based on the budgeted numbers from fiscal 2012 to 2013, and I know we didn't exceed budget. What it cost for all the participants was $77,100. Put the same time in jail, it's $18,250, and in prison, you're $24,000. Drug courts are getting better results so far. They're getting them for less money. Juvenile drug courts. Juvenile drug courts are not quite as widespread in West Virginia, and unfortunately, their development, while still ongoing, and we're still developing new juvenile drug courts, the priority has to, we are not under a statutory requirement to have it completed by a date certain as we are with adult drug courts. But we do currently have 15 operating programs that serve 20 counties in West Virginia. You'll note that Monongalia County, where you all are sitting, has both an adult and a juvenile program. They've been doing a strong job for a long time. A juvenile drug court, I'm not going to sit here and read this because we're getting close to time. I want to leave some time for questions. But the key difference with juvenile drug courts is their programs of early intervention. It is not an addiction court. Juvenile drug court, the philosophy behind its adoption and development in West Virginia was to try and find people early in their life of usage and encourage them away from that. It's more of a preventative measure than it is an effort to address addiction. This is the entirety of West Virginia's juvenile drug court statute. It leaves a lot of work left to be done to define exactly how things are done. We do have a juvenile drug court protocol that has been developed and promulgated and adopted by the Supreme Court. We are preparing and hope to have adopted this year a juvenile drug court policy and procedures manual similar to what we have in the adult drug court now. But it is mirrored closely after the juvenile diversion statute. It's not the same early intervention, and instead of 10 key components, it's 16 strategies, which compare closely, though are a bit more team-oriented. They have a bit more to do with the collaborative process within the drug court. And another key factor in juvenile drug courts is the requirement of family participation. Generally speaking, anyone can become an addict. I would hope everybody in this room is aware of that. I imagine, and unfortunately all of us are aware of it to some degree personally. But generally speaking, juveniles don't develop criminal problems related to drug usage without a home issue. It happens, but there is a high correlation between problems with the parents and problems with the kids. Therefore, parents are required to participate in counseling along with one of the requirements of participation in juvenile drug court. You have to have a parent or guardian who is willing to participate in the program with you. Get to the program, participate in counseling, and become a part of your recovery process. Developmentally appropriate services is another way it's differentiated from the 10 key components because we're dealing with juveniles. We have to encompass educational and other developmental needs as part of a holistic approach to the problems the juvenile's having. It's a bit more, they have specifically identified gender appropriate services here because again, in developmental context, that is a very significant factor, particularly for adolescents. And not being prepared to address gender-related issues in an adolescent context can create a lot of problems within your court, though, quite frankly, in adult drug court, that's becoming more and more of a significant issue. Cultural competence, again, not expressly stated in the adult drug court key components, but it's stressed in all the best practices and national research we're getting now. West Virginia, we have less of, in ways we have less and more issues with that, both adult and juvenile level. We are more homogenous than a lot of areas, but that doesn't mean we are uniform. There are diverse people within our juvenile drug court and adult drug court system. Our officers have to be able, and our treatment professionals and our judges have to and are committed to being able to address those differences, because in taking a strength-based approach, the point to that is identifying the aspects of a drug court participant that will matter the most to them in terms of awarding incentives, in terms of imposing sanctions. If you don't understand someone's background, cultures, and traditions, that's going to be harder to do. Family engagement we mentioned. Educational linkages touches in with developmental. Confidentiality is significant for both programs, though expressly stated more here. Both programs fall under 42 CFR Part 2, which governs confidentiality of substance abuse treatment records. It is extremely strict. Even identifying someone as a participant in a treatment program, which drug court programs are treatment programs under that regulation, is a violation. Violations can be good for hundreds to thousands of dollars of fines. So confidentiality for all drug courts is significant. In juvenile drug court, you also have juvenile confidentiality layered on top of it. But quite honestly, if you're already adhering to the federal regulation, you are very unlikely to run afoul of any state-level judicial confidentiality statutes. A structure with a treatment team, and in this case a planning and evaluation team instead of a local advisory committee, is pretty much similar to adult drug courts. You've got the one group that is involved week to week, knows the participants, is interacting with them, providing them treatment, making decisions about incentives and sanctions. You've got the other group that is monitoring how the program is doing, making sure it's meeting what the community wants of it, and reaching out to the community for the resources, assistance, and guidance the program needs. Target population for juvenile programs, which are very different, obviously, from adult. Not just by dint of the fact that it's juveniles, but again, it's early intervention as opposed to addiction. We don't go younger than 10, and we have had, I think the youngest I'm aware of is 12 that we've had participate in a juvenile drug court program, but I expect it will not stay that way. 17, we usually don't want to target much older than 17. It is at that point you're going to deal with the potential of someone aging out of the program. It will muddy the lines of the authority of the JDCPO in the court over the participant. Again, nonviolent offense is a requirement here, but violent offenses is defined slightly differently. You can have a battery offense as long as it does not result in admission for treatment. However, if it involves a deadly weapon, that's a violent offense that's exclusive. And federal rules regarding drug courts are even more strict, particularly with regard to an underlying offense and the use of a firearm in an underlying offense. And we try to adhere to the federal regulation, even primarily because if you don't, you can't qualify for federal funding. A juvenile with a previous violent offense can be considered on a case-by-case basis. So even if your underlying offense isn't a violent offense, if you have an old violent offense, it could still disqualify you at the determination of the local team. Youth charged with sex offenses or with a previous sex offense are ineligible. Delivery of controlled substance like adult drug court, that's a case-by-case call that the team needs to make. Prescription drug abuse and addiction in the juvenile drug courts is not as significant as in the adult drug courts, which is probably, it makes perfect sense given that it's not an addict-focused program. It's more early use and possession. And that's not what you're going to see if someone's starting to use opioids. However, they are in the top 4, both prescription opioids and sedatives for West Virginia's juvenile drug court participants, and statewide, the report from the JDCPOs is that that's also on the rise. Program length in juvenile drug court average is 28, or minimum length is 28 weeks, average is 32 weeks. It has 4 phases, which closely track the 3 phases of adult drug court. So the 4th phase is a bit more, a phase for graduation in and of itself almost. Between 2007 and 2012, we had 201 participants successfully graduate from juvenile drug court, and the graduation rate was 62%. The cost per JDC participant was $6,403. If you did 8 months of detention in a DJC facility, that'd be $96,000. And if you went to a residential treatment facility, it'd be $44,000 to $99,000. Again, drug courts have an enormous potential to be a savings to the system because incarceration is expensive. And this is a way of dealing with these programs, with watching the offender closely, but not putting them in an incarcerative environment that is highly likely to make them reoffend and that we really can't afford at this point anyway. The recidivism percentage, again in that 2007-2011 window where we had the study, was 14.4% compared to a 51.5% rate for traditional juvenile justice. So not only cheaper, it's turning out to be more effective. And this was based on there was an actual evaluation for the JDCs. This is my contact information. If you want to get anything else, if you all have any questions, I may have run a little fast, but.
First of all, thank you for inviting me. It was 73 in Tampa, Florida when I left yesterday, and it was sunny. Actually, I'm very excited. Snow is an exciting thing for me, having spent the majority of my life in Florida. So I appreciate being here. Hopefully, I'll be able to leave at some point. I'll just get started. We've been talking about prescription drug abuse. As noted previously, the Center for Disease Control and Prevention has classified prescription drug abuse as an epidemic. From 2000 to 2009, there was a 48% increase in filled prescriptions. Specifically, in 2000, retail pharmacies dispensed 174 million prescriptions for opiates. But by 2009, they dispensed 757 million, which is a 48% increase in just the amount of opiates that were prescribed in that 9-year period of time. Currently, drug overdose is the second leading cause of accidental death, second only to car accidents. Women versus men. Women are more likely, 5 times more likely to overdose than are men. Since 2007, more women have accidentally died from drug overdose than from car accidents. Now, I don't know if that's the drug issue or whether men are worse drivers than women, but statistically, women are more likely, it's the number 1 cause of death for women since 2007, accidental death. While use of cocaine statistically has been shown to be down, first-time use of non-prescribed medication is on the rise. Prescription drugs is the second most abused drug, next only to marijuana among young people. The number of prescriptions filled for opiate pain relievers has dramatically increased, specifically 402%. The economic costs. Factoring in public health, crime, and lost productivity, illicit drug use costs the United States an estimated $193 billion in 2007. and that's from the Executive Branch Office of the National Drug Policy. What I wanted to do was give you some insight in the type of defendants that I've represented that have been prosecuted by the federal government in the Middle District of Florida. The first one that we're going to talk about is a client of mine and another colleague in my office, Destiny A., and yes, that's her real name. The second client is Derek C., and the third client of our office was Dr. Jeffrey F. And these are three defendants that were prosecuted in the Middle District of Florida related to the exact topic that we're talking about here today. Let me tell you a little bit about Destiny. She's actually born in Hershey, Pennsylvania, so she's from your neck of the woods. She was 28 years old when arrested in federal court. Her father was 50 years old, unemployed, and suffering from cancer. Her mother was 45 years old, unemployed, and suffering from lung disease. Both her parents had a past history of abusing drugs when they were younger. Her father also had a prior criminal history. Destiny had a 9-year-old daughter and an 18-month-old son from separate relationships. At the time of her arrest, she had lost custody of both. She was a school dropout in the 8th grade, noting that at the time she was abusing drugs and wanted to hang out with her friends as opposed to attending school. Her major form of employment was as an exotic dancer. Destiny first used marijuana when she was 14 and was a continued daily user until the time of her federal arrest. She first used cocaine when she was 16, and she used it on a daily basis until she was 22. She had been abusing alcohol since she was 18. She first tried crack cocaine when she was 23, and continued to use crack cocaine daily for 2 years until she was 25 years old. She had experimented with heroin on one occasion and with methamphetamine on one occasion. She had also used MDMA, often commonly referred to as ecstasy. As to prescription pills, Destiny abused Valium, Xanax, and Dilaudid. She described her use of Dilaudid by opening the pills, diluting them in a liquid, and then injecting them into her bloodstream. As to hydrocodone, she was first prescribed hydrocodone in 2006 after the birth of her child, and she continued to take 40 to 50 pills per day until the day of her federal arrest. She disclosed to us and to the court that she probably would have been dead if she had not been arrested from her drug use and abuse. Destiny's prior criminal history consisted of the following. When she was 16, she was found by law enforcement carrying a Crown Royal bag which contained a crack pipe and residue. When she was also 16, she was later arrested, found in possession of a Newport cigar box containing personal marijuana use quantities. When she was 24, while working in a strip club, she unlawfully exposed her sexual organs and was arrested. When she was 24, she was stopped in a vehicle which she was driving where the passenger was intoxicated and passed out in the vehicle. She admitted to law enforcement at the time that she had a crack pipe and 2 Xanax in her purse. Again, when she was 24, she was observed by police in a known area for drug sales and found to be in possession of 2 pieces of crack, a razor blade, a crack pipe, and personal use quantities of marijuana. Destiny was charged in federal court with the crime of conspiracy to distribute oxycodone and possession with intent to distribute oxycodone. A conspiracy, if you don't know, is simply an agreement between 2 or more people to commit a crime. In federal court, they'll charge conspiracy and then the actual crime. So if 2 people agree to rob a bank, that agreement to commit the crime is a conspiracy to commit bank robbery. If you then go rob the bank, that's the crime of bank robbery. Factually, this conspiracy consisted of what's referred to as the doctor-shopper conspiracy. And what that involves is people who are trying to obtain prescriptions drugs, usually oxycodone, by fraud, is they will locate individuals who are willing to go into doctor's offices, pretend to have an injury, or actually do have an injury, get the prescription filled for them, and then give them to the people that have sent them in there. And that's what was taking place in this particular conspiracy. The leader of this conspiracy was Destiny's boyfriend, or at least she perceived him to be her boyfriend, although I think factually he had several girlfriends. He had entered a strip club where she was working, engaged her in probably lots of things, including a conversation, and told her that she could make more money if she would just go into these doctor's offices and get these pills. It was this boyfriend who got Destiny addicted to the use of oxycodone. Ultimately, Destiny started out in this conspiracy as a fake patient. These cases are amazing. They actually get other people's MRIs, other people's X-rays, other people's medical records. They doctor up medical records, and they go into either the pain clinics, where you don't really need all that, the pill mills, or into legitimate doctors' offices and feign injury to get these prescriptions. Destiny went from being a fake patient to ultimately being the bookkeeper for her boyfriend because there were so many individuals that they were sending into the doctor's offices who needed to be paid and they needed to collect the pills that she actually became the bookkeeper and had ledgers of who was going into what doctor's offices. They would actually travel from town to town. They'd go to Orlando, they'd go to Tampa, and they would hit these different areas where they would place them into hotel rooms before they brought them into the doctor's offices. Destiny was held responsible for 51,600 milligrams of oxycodone in her conspiracy. She pled guilty to conspiracy to distribute and possess with intent to distribute oxycodone. That particular statute is 21 United States Code, Section 846 and 841B1C. Statutorily, that crime carries a minimum penalty of probation and a statutory maximum penalty of 20 years imprisonment. Ultimately, the way the federal sentencing system works is it takes into consideration your criminal history, and you get a criminal history score, but it also looks at, in a drug offense, what drug were you convicted of possessing or distributing, and how much drugs were involved. There's actually a table in the guideline book, and what I did is I listed several common drugs, so you can kind of see how the Sentencing Commission, which is the organization that puts forth the sentencing guidelines, views oxycodone and hydrocodone. Ultimately, every drug that's penalized is somehow converted to marijuana. And like, how much more serious is this drug than marijuana, in sort of layman's terms. You'll see that cocaine is considered by Congress and the Sentencing Commission, 1 gram of cocaine is as serious as possessing 200 grams of marijuana. Oxycodone actual, 1 gram, is as serious as possessing 500 grams of marijuana. Hydrocodone, also 1 gram, as serious as possessing 500 grams of marijuana. You'll see heroin is considered twice as serious as possessing hydrocodone. Crack cocaine, 1 gram, is equal to 3,571 grams of marijuana. And then methamphetamine, which is, I guess, the most serious drug, at least considered by the Commission, 1 gram equals 20,000 grams of marijuana. So you can kind of see how the federal system views this prescription drug epidemic in its sentencing process. In this case, 51,600 milligrams that she was involved with was the equivalent of her possessing 345.72 kilograms of marijuana. Her sentencing range, taking into consideration the criminal history that I told you, the quantity of drugs involved, was 84 to 105 months. The federal system loves to use months instead of years. I think it's so you don't think it's so bad, but you become pretty good at converting months to years in my profession. That's 7 years to 8 years, 9 months is what the sentencing range was for her offense, which was basically being manipulated by her boyfriend to go into doctor's offices and get pills, which she took 40 to 50 a day. and being the bookkeeper. She was sentenced to 7 years in prison to be followed by a 3-year term of supervised release. Supervised release in the federal system is like probation. It is probation. We call it supervised release. We do everything different, which follows a jail sentence. She's still serving that sentence in Aliceville FCI. Her projected release date would be December 17th of this year. The cost of incarcerating Destiny A, in 2010, it cost $25,894.50 per year to incarcerate somebody. That number's gone up by today's dollars. It will cost approximately $181,261.50 to incarcerate that individual which I previously described to you in the crime that she committed. Derek C. is a client that I personally represented. Derek was born in Cooksville, Tennessee. He was 25 years old at the time he was arrested federally. His parents were divorced. His mother was an alcoholic. He had a rocky relationship with his mom because of her alcoholism. At age 15, when his parents separated, he was placed into a foster home. He barely ever knew his biological father. His stepfather had a prior criminal history. Derek dropped out of high school in the 11th grade with a GPA of 1.85. He had very limited work history. Previously had only worked a few months at a Burger King. Derek had a drug abuse history dating back to when he was 11 years old. He started smoking marijuana fairly regularly when he was 12, and he was a daily user of marijuana until the time of his arrest. As to cocaine, he used both powder and crack cocaine on and off since he was 17 years old. He was a frequent user of methamphetamine since he was 22 years old. He had experimented with heroin and ecstasy in the past. As to his prescription pill use, he was a daily user of roxicodone and oxycodone for 1 year prior to his federal arrest. Derek had no prior juvenile criminal history. When he was 18, he had a driving while license suspended conviction. When he was 19, him and an equal-aged friend entered a home with a firearm and attempted to rob the occupants of that home. When the occupants said they didn't have anything, they turned around and left. He was charged with robbery. When he was 23, he was charged with disorderly intoxication when he was found by police outside a liquor store yelling at patrons and using vulgar language. Like Destiny, Derek was also charged with the conspiracy to possess with intent to distribute and to distribute oxycodone. There were 13 co-defendants in his conspiracy. Derek, who was from Tennessee and not from Florida, was involved in a conspiracy where individuals from Tennessee were traveling from Tennessee to Florida because we have these wonderful pill mill, and doctors are willing to prescribe prescriptions of pain medication to anybody that walks in their door. So they were coming down from Tennessee, and Derek was involved in that process. There was large quantities of oxycodone pills that were being transported from Florida back to Tennessee in this conspiracy. They used commercial carriers, they used the U.S. Postal Service, and they used drug couriers, which are just individuals that would drive down, pick up the drugs, and bring them back. The leader of this conspiracy was in Tennessee. There was a person as part of this conspiracy who actually resided in Florida. He actually worked as a security guard at a pharmacy. So he had some connections at the pharmacy. So when the prescriptions were unlawfully being obtained from the doctors, they would go to this particular pharmacy where this security guard worked. and the prescriptions were more readily filled. There were individuals in this 13-person conspiracy that were recruited. This is a doctor shopping that would go into the doctor's offices with and obtain the prescriptions. They used fake MRIs and fake patients. There was doctor shopping. Derek's role in this conspiracy is he was the driver for the leader of the Tennessee conspiracy. Although the guy in Tennessee was willing to break the law by distributing large quantities of oxycodone, he did not want to drive without a valid driver's license. So he recruited Derek, who was a daily user of these pills, to drive him to Florida to pick up pills, to drive him to deliver pills, and in exchange, Derek received pills for himself to get high. Derek was involved in the distribution of between 15,000 and 25,000 pills. Those pills were 30-milligram oxycodone pills. Like Destiny, Derek pled guilty to conspiracy to distribute and possession with intent to distribute oxycodone. Like Destiny, he was guilty of 21 United States Code Section 846 and 841. Like Destiny, he was facing a sentencing range of as low statutorily as probation and a maximum sentence of 20 years imprisonment. We were talking about 450,000 to 750,000 milligrams of oxycodone. Derek, in the federal system, they do give you a reduction if your role is less serious than other participants. I was able to persuade the court and the prosecutor that Derek was entitled to a minor role reduction, which lowered his sentencing range some. We were unsuccessful in convincing the court that Destiny should receive a minor role reduction. Back to our sentencing table, we know we're talking 1 gram equals 500 grams of marijuana. What Derek did, according to the federal sentencing guidelines, was the equivalent of possessing 3,105 to 5,025 kilograms of marijuana. His guideline range was 70 to 87 months. He did cooperate and testified, was willing to testify against the people that had recruited him. He received a reduction. He was sentenced to 41 months because of that cooperation, followed by 3 years of supervised release. He was released last year in October. The cost for Derek at the time in 2012, it was $28,284.16 annually to incarcerate him. It's cost you as taxpayers $101,331.76 for that 41-month sentence of incarceration that he received. Neither Destiny nor Derek received any drug treatment when they were in pretrial detention. I'll talk about the programs that were available for them and the programs that will be available for them when they're on supervised release. The third individual is Dr. Jeffrey F. I did not personally represent Dr. Jeffrey, but another lawyer in my office did. Dr. Jeffrey, life story, as you can imagine, is dramatically different than Destiny's and Derek's. I didn't plan this, but he was actually also born up here. He was born in Pittsburgh, Pennsylvania. He was 51 years old at the time of his federal arrest. He described his childhood as being very comfortable, supportive, and a loving environment. His mother was a housewife, and his father was a pharmacist. He was divorced, and he had no children. He was a high school graduate from Bethlehem Center High School in Frederickstown, Pennsylvania. He received his BA degree from Washington and Jefferson College in Washington, Pennsylvania. And he received his medical degree from American University in the Virgin Islands. Dr. Jeffrey did not have a drug abuse problem. Dr. Jeffrey did not have any prior criminal history. And unlike Derek and Destiny, he did not work as a stripper or at a Burger King. He began his practice as a doctor in 1985, where he worked at an urgent care center in St. Louis, Missouri. From 1986 to 1987, he worked at St. Joseph Hospital in Kirkwood, Missouri. From 1987 to 1988, he worked at an urgent care center in Cape Coral, Florida. From 1988 to 1991, he worked at Dade City Medical Arts in Dade City, Florida. From 1991 to 1992, he worked at Ed Fraser Memorial Hospital in McKinney, Florida. From 1991 to 1995, he did a neurology residency, and then he became the chief resident at State University of New York in Syracuse, New York. From 1995 to 1996, he worked at the State University of New York in Syracuse on a fellowship related to pain management. From 1996 to 1998, he did clinical research investigator for the University of South Florida, College of Medicine, Department of Neurology in Tampa, Florida. From 1999 to 2002, he was the assistant clinical professor for the University of South Florida, College of Medicine, Department of Neurology in Tampa, Florida. And then from 2005 to 2009, and this is the employment that got him in trouble, he was the medical director of the Neurology and Pain Centers in Tampa, Florida. Dr. Jeffrey was charged with conspiracy to distribute and dispense controlled substances not for legitimate medical purposes. He was also charged with Medicare fraud, because if you're billing Medicare for treatment that's not needed, that's Medicare fraud. His particular conspiracy involved pain clinics, often referred to in my wonderful state as pill mills. What happened in his conspiracy, his co-conspirators was a physician assistant and an emergency medical technician. And what was happening is they were fraudulently providing medication to patients of the pain clinic. The clinic actually had locations in Tampa, Lakeland, Florida, Sarasota, Orlando, and Jacksonville, Florida. Medication was being prescribed without patient medical necessity. Because Dr. Jeffrey had to be at these 4 different clinics, and he couldn't be there every day, and yet they had patients at every clinic, he was pre-signing the prescription pads so that the physician's assistant and the emergency medical technician could just give the prescriptions out when the patients came in, and that way he could be in 4 places at one time, which really was the downfall and what really put the government's case together. In addition to this part of unlawful distributing of oxycodone, the physicians and the assistant and the emergency medical technician also had their side deal going on where they were forging prescriptions and taking them and getting them filled and then distributing oxycodone on the street. So it wasn't just pills that were going out to patients that came in without medical necessity, but these 2 co-conspirators also had their sort of street sales side business. Dr. Jeffrey pled guilty to conspiracy to distribute and dispense controlled substances not for legitimate medical purposes. That's the statute. Similar to Destiny and Derrick, the statutory penalties for that particular crime is also a minimum of probation, a maximum of 20 years. The amount of oxycodone, as you can imagine, was dramatically higher that he was being held responsible for, because we're talking about 4 pain clinics over a several-year period of time, was 2,249.037 grams of oxycodone. Back to our sentencing table, that equals 15,068.54 kilograms of marijuana, is what the sentencing guidelines said his conduct was comparable to. His sentencing range was 135 to 168 months. He provided a little bit of substantial assistance as well. He was ultimately sentenced to 9 years in prison. This is an individual who's never been to prison before, college professional, followed by 3 years of supervised release. I'm not sure why. I probably will look into this, but for some reason he ended up at a penitentiary. Maybe they're making him work as a doctor there, because penitentiaries are really designed for the most violent, most dangerous offenders. Dr. Jeffrey, despite his flaws, certainly wouldn't fit into that category. I'm not sure why he's been sent to a penitentiary. He's not projected to be released until August 16th of 2018. The cost for incarcerating Dr. Jeffrey for this offense, in 2010, it was costing $25,894.50 per year. because she was taxpayers $233,050.05 for the punishment that he's received for his criminal conduct. Looking at the total cost for all three of these defendants, we're looking at over $500,000 for these three prosecutions just within the Middle District of Florida. All three of these defendants had co-defendants. If we look at those numbers, Destiny had two co-defendants, one who received 15 years, 8 months, that was her boyfriend, and then another co-defendant who received 24 months. In total, for that one case, those three defendants, it is going to cost us taxpayers $638,732.32. For Derek's case, which had 12 other co-defendants, if you add up all of the sentences they've received, there's still 3 of them that are pending trial in July of this year. That's over $2 million for that one case in cost of incarceration. Dr. Jeffrey and his two co-defendants, it's total $543,785.22. If you take all 3 cases combined, just cost of incarcerating the defendants involved in those 3 cases, $3,829,420.01 for those prosecutions. Currently in the United States, there are nearly 7 million Americans who are under supervision of the state or federal criminal justice system. Approximately 2 million of this 7 million are currently incarcerated, with the remaining 5 million on supervised release, probation, or parole. In the federal system, as of 2 weeks ago, there is 173,417 people currently in federal prison. As I noted today, the annual cost for those 173,000 is $28,948 to federally incarcerated defendant. Coincidentally, if they were on community supervision, each one of those defendants per year would only cost $3,347.41 to supervise. These are the actual most recent costs. On the left-hand column, you'll see prison. In the federal prison system per day, it's $79.31. A halfway house, which is pseudo-prison, but you get to go into the community and work, it's not dramatically cheaper than prison. That's $73.75, whereas probation is $9.17. And then we have the monthly costs and the annual costs. Drug treatment. We know that studies have shown that there are too many people who need it and not enough getting it. One study showed that there were 23.1 million people in the United States who needed drug treatment. But the year prior to that, only 2.6 million of those 23 million were actually receiving drug treatment. Drug treatment saves money. Research shows that every dollar spent on substance abuse treatment saves $4 in health care costs and $7 in law enforcement and other criminal justice costs. On average, substance abuse treatment costs $1,583 per patient, and the economic cost of not providing treatment per patient is $11,487, which represents a greater than 7-to-1 ratio of benefits to costs. In the federal system, there's really 3 phases where somebody could receive treatment if they have a drug addiction problem. There's the pretrial stage. That's when you've been arrested and you're awaiting trial. You could either be in custody because you were not able to receive bond, or you could be in the community on what we call in the federal system pretrial supervision. There's the incarceration stage, and then there's the post-sentencing stage, because in federal criminal justice system, when you get out of prison, you're still on court supervision. It's called supervised release. It's like probation to follow your jail sentence. The problems with drug treatment in the federal system in the pretrial stage, like everything else currently in the federal system, is there's a very limited budget. There's just not funding for appropriate treatment. There is no inpatient treatment available. So let's say Destiny comes in. We know she has a serious drug addiction problem. We know she's in need of treatment. She wants to get treatment. She's released on bond. She needs inpatient treatment. because if she's on the street, she's going to use. It's not available to her. They do have outpatient treatment, and she will be drug tested. She tests positive once, her bond's going to be revoked, and she's going to go to jail. As one of our prior speakers noted, that's really not an effective way to treat somebody with an addiction problem because relapse is part of rehabilitation. There are no pretrial drug treatment inside. If you're detained, you don't make bond, there is no drug treatment in a federal pretrial detention facility. In my district, we don't have a federal pretrial detention facility. If you're detained, you're in one of our county jails, and they don't have any pretrial drug treatment available while you're awaiting disposition of your case. The Bureau of Prisons does have a 50-hour drug treatment program when you're in prison serving your sentence. You don't get any benefit for completing the 50-hour program other than self-worth improvement while in custody. They also have a 500-hour residential drug treatment program. It's called the RDAP program. That program is the most demanded program within the federal prison system because it's the only program you can complete when in federal prison that will reduce your sentence. If you successfully complete the RDAP program, you can get up to a year off of your sentence. There is a very high demand for that program. It's like impossible to find the statistics from the Bureau of Prisons. They're very secretive about such things. But they told us when we called them that there are presently 7,400 inmates currently participating in the RDAP program. That's 7,400 out of the 173,000 individuals that are in federal prison. I would suggest to you that 80% of everybody that's in federal prison has a substance abuse problem for which they could benefit from treatment. At any given time, there are several thousand on the waiting list for this single program. Not every federal prison has the program. If you have violence in your criminal history, you're not going to get into that program. And if you are lucky enough to get into, or if you possess a firearm, you're not going to get into that program. Supervised release, which is the supervision that you're going to get when you get out of prison, does have drug treatment, and it's standardly imposed as a condition of your supervised release. However, for budgetary reasons, there are no residential drug treatment programs when you come out of prison in the federal criminal justice system. So it's all on an outpatient basis. Because it's a federal agency, you're getting the lowest bidder to provide those services. Typically, the lowest bidder is not necessarily the best provider. As we've discussed earlier today in this program, I am a true believer that the criminal justice system is the worst place to try to address an addiction issue unless you're in a drug court program. And that's simply because a lot of judges, when you're on supervision, you test positive, they have zero tolerance, they're sending you back to jail. Well, you were just in jail for a very long period of time, and that did not fix your drug problem. So the notion that we're going to send you back to jail when you test positive for drugs is going to do nothing but cost the taxpayers money to have you sit there until you get out of jail and continue to have your drug problem. In our district, typically you won't be violated. The petition won't go to the judge unless you test positive 3 times, although there are some judges that impose a zero tolerance process. Drug courts. The last speaker touched on some of this, but for every dollar spent on drug courts yields more than $2 in savings in the criminal justice system alone. According to a recent Department of Justice study, which is amazing to me that the federal government funds and gives funding to state courts for their drug court programs, but do not have a drug court program in the federal criminal justice system. Drug court participants reported 25% less criminal activity and 60% fewer arrests than comparable non-drug court participants. 26% fewer drug court participants reported drug use and were 37% less likely to test positive for illicit substances. Drug courts significantly reduced crime by an average of 26%, whereas well-administered drug courts were found to reduce crime rates by as much as 35%. Federal drug courts. As of April of 2013, there were 0 federal drug courts, and as of today, there are 0 federal drug courts. In comparison, there are 2,383 drug court programs currently operating in the United States. There are additional 198 drug courts being planned in the state criminal justice system and still 0 federal drug courts being planned in the federal criminal justice system. 1,537 out of the 3,147 counties in the United States currently have or are planning to have a drug court program. While we don't have drug courts, which is a program that's typically to divert you from going to prison, we're not going to send you to prison, we're going to put you in drug court. The federal system 6 years ago started what's called a reentry program. And it's kind of like a drug court, but it's really not. What these programs are designed to help you when you come out of prison. So you've already gone to prison, you're coming out of prison, you're going to be on supervised release in the federal system, but you can volunteer to be in a reentry program in which you're going to have more intensive supervision. You're going to come to court regularly, just like a drug court would on the front, and see a judge, and there's a prosecutor, and there's a probation officer, and there's a defense lawyer, and it's positive reinforcement with graduated sanctions when you mess up. Presently, 41 districts have reentry programs. There's 94 districts in the United States. Generally, these programs are relatively new, but studies have shown that they have been successful in reducing recidivism. These reentry programs, especially the program in my district, which I volunteer to participate in, targets the most likely people to reoffend. The highest risk of reoffenders are the only ones allowed in the reentry program. Typically, they do have some substance abuse issues, but they're not necessarily addicts per se. But they have substance abuse, and they have high likelihood of recidivism. Incarceration versus treatment. In 2010, 23.1 million Americans aged 12 or older needed substance abuse treatment, but only 2.5 million people received it, which is the stat I had noted to you before. Every dollar spent on substance abuse treatment saves $4 in health care costs and $7 in law enforcement and other criminal justice costs. Dollar for dollar, treatment reduces the societal costs of substance abuse more effectively than incarceration. And this was an interesting study that I found. Therapeutic treatment in prison is good, and it saves us money, and it helps reduce recidivism. But the studies have shown receiving treatment in prison has a cost benefit of only $1.91, whereas community-based therapeutic treatment has a cost benefit of $8.87. And the reason that is statistically we know that the things that are most likely to lead to recidivism or to reduce recidivism is employment, education, sobriety. When you go, and support staff, family support. When you go to prison, you lose your employment, you lose your family support oftentimes, and it becomes very difficult when you come back into the community to reestablish. One thing that I've learned participating in a reentry program is how incredibly difficult it is for individuals who have gone to prison to come back into society and not go back to using drugs or not go back to committing crime. They have nothing. They don't have driver's licenses. In our state, your license gets suspended if you commit a drug offense. So you come out, you don't have a driver's license, you don't have employment, you're a convicted felon, and it becomes far more difficult to make it and to not turn back to the drug activity that you participated in prior to going to prison. Offenders who completed drug treatment showed a nearly 2/3 decline in overall arrests and over a 50% drop in drug possession arrests. A RAND study found that drug treatment for a heavy drug user was 3 times more effective in reducing recidivism than mandatory minimum sentences. And so, you know, the federal response to the prescription drug epidemic has been the response to everything. At one point, it was the crack cocaine epidemic. At one point, it was the methamphetamine epidemic. Now it's the prescription pill. In our district, it's starting to become this new drug Molly. And the response consistently have been incarceration. Increase the penalties, incarcerate them longer, but yet all of the studies show that that does not reduce recidivism. And there's also a lot of studies that show it doesn't have a deterrent effect. I personally agree that the Dr. Jeffries of the world can be deterred. by 9-year sentences. I think that has a significant effect, and I truly believe they can be deterred by being prosecuted for second-degree murder. Their criminal activity is a cost-benefit analysis, and it's a money-driven thing, and it's not worth the money if you're going to go to prison for 9 years. That makes a logical, general, specific deterrent analysis. When you're dealing with the Destinies and the Derricks of the world who are addicted, whose part of their brain doesn't think rationally, it thinks about how am I going to get high, how am I going to support my habit, incarceration has no effect of deterring them from committing another crime. And statistically, we know that. Drug treatment has a significant effect of preventing them from committing another crime. And as the last speaker noted, these drug court programs and drug treatment is less expensive. So what I would suggest that we do to address this epidemic and all epidemic is to reinstitute drug treatment programs outside of the criminal justice system. As one of our speakers talked, we don't need to be referring people with drug problems to the criminal justice system. There needs to be programs available outside of the criminal justice system. And if you're in the criminal justice system, it needs to be a drug court, positive reinforcement. We understand your problems. We're going to help you through these problems. We're going to help give you the support that you need to overcome these obstacles that you're having so you don't just go get high to forget your problems or to escape your problems. It's more cost efficient. It's going to reduce crime at a greater level. Unfortunately, it's much easier if you're a politician to be tough on crime and to be part of the war on crime and to be, we're going to be tough and we're going to incarcerate these individuals. And that's really what we saw in our district between 2010 and 2012, a whole rash of these type of pill mill cases where these individuals are being prosecuted and they're all still in prison or be getting out of prison with little or nothing to prevent them from going back into that type of criminal activity in the near future. Thank you.
So you just looking at the issues, if you look at prescriber education, mandatory prescriber education, there's a very strong physicians lobby against the additional mandate. They think that they have enough that they're told to do. They don't need more that they're told to do. If you look at rescheduling hydrocodone, the main lobbyists behind that are the chain drugstores. So the big pharmacies that have presence on every street corner are against that. We talked about the issues associated with the prison contracts. The prison lobbyists are very strong, especially in the states. They want to fill their prisons instead of sending people otherwise to treatment. The generic pharmaceutical companies are the ones who are not doing what is necessary to shift the market to the safer medications, and in fact, they're pushing back a little bit against the transition of the market. And then the insurers are denying care, and we need to make sure that we stand up against the insurers in light of the new laws that provide treatment benefits under the Affordable Care Act and the Equity Act.
I think it's easy to not think about it. I think about it because I'm representing the destiny of the Arabs every day in front of me and dealing with it. I think it's easy to just not deal with it. I think it's difficult to change your philosophies on criminal justice punishment versus rehabilitation. They tell me, I should have practiced law in the 70s, it was all about rehabilitation. And then fixing the war on drugs, which we continue to do on Oregon's continue, drug czars by the president and cracking down, you guys don't know it, but I know it, my district hard Navy is off the coast of Colombia right now, with Coast Guard personnel waiting to interact boats that have tons of money for gain. And we are conducting military type operations off the coast of Colombia right now, and just grabbing Colombians off boats and then in the United States for prosecution. In my lifetime of practicing law, it's always been, tough on crime. All I've ever seen is the punishments go up, whether it be DUI law, whether it be child pornography, whether it be drugs. Every year the crime reports come out, and crime's going up, and crime's going up. Well, we need to just incarcerate more people for longer periods of time. And that's just been the response for years. And the judges that I'm appearing in front of now, because those policies not non-official, really no name for the advisory, are so systemically ingrained in incarceration. And Steve talked when they first started their drug court program, the judges were like, one positive and you're going to jail. Their rules, and you've broken the rules, and the solution to rule breaking is punishment, which every scientist would tell you no. It's when you're an addict, your brain is functioning on a different part of your brain. It's not a rational response system that's going to respond to that. But there's a giant disconnect between the policymakers and what all the studies are showing. There has been a little bit of push with this current administration to look at alternatives to that. In fact, the president recently asked for more clemency petitions for non-violent drug offenders because he wants to release more people from prison. The Attorney General, the current Attorney General, has instituted some policies to peel back some of these mandatory penalties. But I think, from my perspective, it's really getting people to want to look for an alternative way to do it, and not say that this is how we've always done it, this is how we've always dealt with this issue, and what's wrong with it? I'm not going to jail. They should have not used drugs. I mean, it's like people think it's a conscious decision that you can just make. Oh, I'm going to get high today, or I'm not going to get high today. Yet the scientists tell us that that's not how your brain is functioning when you're having that urge to get high and an addict's having. There's just this disconnect, and I don't know if it needs to start from the early level of education about how this process is working. But ever since we've started this war on drugs, it's been about more law enforcement, it's been about longer sentences, it's been about minimum mandatories, it's been about incarcerating, which has created these large interest groups that are profiting off of us. Unless somehow there's a profit incentive to do something different, actually looking at their asking office to give studies, to give information, because of the current budget situation, and if nothing else, we can save money. And that seems to be gaining some traction with those that want to change the system to dollars and cents. And if you're actually reducing crime too, and that just seems to be all the better, but there's such an urge to punish as the ultimate goal in the justice system. Not necessarily to stop other crime, but just the eye for an eye mentality.
I can say so far in West Virginia, we have not faced any sort of organized lobbying opposition to what we're doing. At worst, what we face is rather defined resistance. And part of it is what Mr. Allen was talking about. That is just resistance to try something new, try something different, particularly coupled with a lack of understanding of what is being proposed, a lack of understanding about what abortion is, a lack of understanding about how drug courts work. The phrase in your comments that this was another hypothetical. When I was coming into it, to me, it seemed like it's something that everyone should be able to get behind. If you are stereotypically leaning conservative person, there is a strong fiscal element with this system. If you are stereotypically leaning progressive person, there is a strong personal initiative and care element that makes sense. You remiss when you talk about just the individual instances you see in the workforce, where family members get up to reservation and talk about you gave me your mom, you gave me your son back, you gave me the person. That phrase is used over and over and over in every workforce that I see. But it just seems there is this one thing I have accounted for, which is this commitment to a punitive standpoint. And I'm happy to tell them that while it's certainly not the intention of the people this application, there are other districts people in here. They're not happy being that particularly long. There are all of our eventual judges will tell you they have certain participants who would rather go back who decide to go back to face their sentence rather than take the oath. They're high risk, high people who are not unacquainted with the incarceration system. Many of them have adjusted to it. And that's something we're used to and can negotiate, whereas this actually with a self-guided sober life is not. And it's harder for them and less fun. But you say it's a compelling case, and I believe it's right. I hope it is. But it's a case that you're hearing. And it's a case that anytime our office has an opportunity to make it, we go and make it. We're very appreciative of this opportunity to make it big day. But there are people who are unwilling to listen. There are people who, when you tell us to them, will not see past their current. You can't reason someone out of a position that is reason something.
One more question, and we'll be done today. So, Sarah.
Kind of related to Michael's question along another side of things. It seems like one of the common themes of each of your presentations has been state systems seem at least more willing to try to innovate in the first place. Why do you think states are more willing to try new things like drug courts or legislative programs that Congress or federal specifically won't do?
You have to be in both. It's sort of, I always tell people, like, I did a speech in the bar for January and my topic is federal court. Going to state court is like going to New York City. It's just crazy. Just stuff going on and people are coming to court and everything else. And when you go to federal court, it's like going to events. If they were going to be there, you're the only one there and you drill in about 2 hours. It's very painful. You don't like doing it. As an institution, federal court is just, it's the last thing you say from every level of it, from how they do punishment to how they let lawyers behave. You can't leave the podium when you're talking in front of a jury. I mean, there's just,
From my perspective, the issues of substance use deal largely in safety, public welfare, to some extent morals, whether it's right or wrong that it should be included, and then health, right? So all of those are the plenary police powers. The states should be dealing with those particular issues. The federal nexus is interstate commerce, and so we see that the federal government is largely dealing with the substance use problem, especially prescription drug abuse, through the Controlled Substances Act, slowly, but yes, through the Controlled Substances Act, Food, Drug, and Cosmetics Act, and to some extent through Biologics and maybe Public Health Safety Act. But so on the prescription drug abuse issue, they're doing what they need to be doing at the federal government, albeit slowly. The question then that we then go to is whether or not they're appropriately managing their criminal justice system once they've got people in the system, and that's, I think, where there needs to be reform at the federal level.
Thank you. I think I speak for myself, but I suspect some people agree with me that I learned, I think I knew like 1% of what, I mean, I learned 99% of my current knowledge about this topic here today, and I really appreciate, and I know the law review really appreciates you coming through difficult weather conditions to be here, and I suspect you've inspired some people over today. So thanks very much for being here.
Thank you all. Oh, great job. I enjoyed the presentation. I took some notes.